Everyone, and welcome to the Demystifying NHS Finance Study Day. We're going to just go through some little bit of housekeeping, and then we'll get going with the start of the presentations. So this is a NHS England sponsored event. It is very much a basics introduction. It is about the principles of the subjects we're talking about rather than the specifics to your organization, because there will be variations throughout England in your different organizations and regions. There are various different talks, some of which are may or may not be relevant to you, so feel free to drop in and out of the talks as you wish. The sessions are recorded. Most of the slides will be sent out to you. So at the end with a feedback form, and so you shouldn't have to take loads and loads of notes. So my name is A.K. Maheshwaran. I'm a consultant anaesthetist in Leicester. I'm also the clinical lead for the One NHS Finance programme. I'll be doing a few talks, so you're going to be stuck hearing my voice a little bit today, because I'm filling in for a couple of people that are away. So to start with, we're going to just do a little bit of an introduction to finance in the NHS, a much more overview of how it works, and then as the day goes on, we'll be focusing more on specific elements. So why is this important? Why are we talking about this? Why is there a whole study day about it? You've seen today, not today, but just recently, that there's a lot of discussions about funding of the NHS, how it's been underfunded, issues with not having enough money being tight. It's felt very tight in terms of, if you talk to people around, everybody feels that this year is particularly hard in terms of the financial kind of frameworks and limitations that we have. And you see lots of headlines. But funding issues in the NHS aren't a new thing. These are headlines from many years now. So why does it feel bad, particularly this year? And we're going to try and address some of those questions. We'll talk about how spending has changed, what's happening, and what we think might be developing in the future. Okay, so that's the purpose of the first bit of this talk. The other thing we're going to talk about is the idea of the day is to help you navigate the health system. It is not to make you into accountants. It's not about saving money per se. It's about preventing waste and making sure we use the money that we have in the most effective way that we can. If we save money in one area, we can spend it in another. It's not about penny pinching, saving money. It is about helping you navigate the health system to improve the services that you run so that we can deliver the best possible care for our patients. Okay. So the mantra that we try and follow is that we always need to be clinically driven. That needs to be what we do, putting our patients at the forefront of what we deliver, but aware of the financial consequences and the financial limitations that a finite health system has in terms of what we can achieve and what we can do, and we're trying to drive this forward. So to do that, we have to deliver the best value that we can in healthcare. And you'll hear that a lot in various talks throughout the day. But what does that actually mean? Okay, so what is value in healthcare? The kind of academic definitions, that there are three types of healthcare value in healthcare. There's something called allocative value, and that's how resources are allocated, and it can be done at national level, regional level, and to a certain degree an organizational level. Okay. And that's called economic value. What we're going to be focusing on is this concept of technical value, which is how we best make use of the resources that we have been given or we have been allocated. Okay, so we've been allocated some resources. How do we make best use of those resources? And that's called efficient value. And the final thing, which is becoming increasingly important, is that this concept of personalized value, in that what our patients may value in terms of prioritize will be different, may be different. To illustrate this, I can give you two examples. One is a kind of more academic example. So they did a health board in Wales got we did some work with the Virginia Mason Institute. So the Virginia Mason Institute is a big health system in the US who really championed value-based healthcare. And in this Welsh system, they did something very simple. They asked patients what they wanted out of the consultation. This was in this particular example, this was a neurology, so about brain disorders. They asked what they were prioritizing and what they wanted out of the consultations, and they did the same thing with the clinicians. The clinicians were focused on diagnosis, on preventing disease progression, and treating the disease. The patients were focused on more sleep, more energy, ability to function day to day. Now, in most cases, those will align. Those two parallel values will align, but they are different. In my own practice, so I see patients for major operations involving the bowel. And at one end of the spectrum, you have people who are who have different kind of priorities in terms of their quality of life. And if I say to them that you might live longer, but actually you may end up with a lower quality of life than you currently have. There are some people that actually go, no, actually, I'm quite happy with my level of quality of life. I don't have any symptoms. I will take whatever I've got left in terms of time and maximize it to best I can, rather than risk reducing my quality of life to a point where it's not good for me. At the other end of the spectrum, there are people who are potentially quite high risk, but the thought of having cancer just means that they can't live with themselves. So they're willing to take any risks to get rid of that and have that operation. So there are differences even within that pool, and that's just something to appreciate and understand, that personalized value is something that's important and is not always factored in. It's also called effective value. Okay, so we've focused back on that technical value concept, and this is a finance talk or finance day, so we're going to try and make this into an equation. So if we say what value was, and we're going to try and think of, and I'm not ask you to put it in because there's probably too many other people on the call, but think of what one word you'd like to put on the top line and what one word you'd like to put on the bottom line. I'll give you maybe 10-15 seconds to think of a word that kind of encompasses what value means over the numerator and denominator. Now, some of you may be thinking about the concept of outcomes. Outcomes is probably what's been traditionally used in this equation, but it doesn't fully encompass all the different factors that you need to really consider. So the word that's generally used now when we're trying to push is quality. Okay, so value equals quality over the cost in this context. Okay, but then how do you define quality? What is quality? Okay, there are three domains of quality, and if you look at your quality commitment or quality strategy within your organization, they talk about these three domains. And this is important for when you're trying to drive service improvement, when you're trying to do deliver, buy new kit or whatever. You need to show an improvement in value. You need to show it's value-based. So how do you do that? Well, you need to show an improvement in quality. If you don't know what quality is, then we need to look at that in a bit more detail. So there are three domains of quality. One is clinical outcome, and there's no specific clinical outcome that you have to use. It can be patient-reported outcome measures. It can be mortality. It can be length of stay. It can be complications. It can be anything that is relevant to what you're measuring. Okay. And an example would be, and I apologize, most of my examples are, surgical or at least hospital-based. My surgical colleagues have had a different way of closing the abdomen. So yeah, after a big laparotomy, so a big cut in the abdomen, they had a slightly different way of closing it. It added half an hour onto the operation, and it didn't affect pain scores. It didn't affect length of stay in hospital. It didn't affect the standard readmission rates or any of the standard metrics that you would normally measure. What it did do was over 5, 10, 15 years, it reduces the rate of that hernias in that wound site. And hernias in those big wounds are quite invasive and can require quite big operations and a significant hospital stay. So by preventing that, it's a significant improvement. But it wouldn't have been captured if you measured the standard outcomes. So you find the right outcome for your for whatever you're trying to show. The other one is patient experience and patient safety. So staffing levels, staff morale, all of that fits into those areas. So they will affect patient safety. They will affect the patient experience. Okay. So that's why these three were chosen when this concept was first introduced. And then cost. So cost can be divided into two areas. Okay, so most budgets are divided into your revenue costs, which are your day-to-day running costs. They tend to recur, so that they're ongoing costs. Mostly staffing is probably the biggest cost in the NHS. So they're your day-to-day costs, consumables, staffing. Your capital costs, as your one-off, they tend to be bigger costs. So one-off purchases, whether it's new buildings, whether it's big CT scanners, whether it's one-off equipment purchases. Okay, non-recurring, and that tends to be your capital costs. Okay, so you have two different types. Now, Michael Porter, when he first came up with this concept, said there was two parts to this. If you improve quality, you will reduce costs. So the problem is, it may not be the cost to your particular department. It may not even be the cost to your organization. It may be cost to the wider health system. It could be societal benefit and societal costs. So, if there are more people in work, that has economic benefits and reduces the costs of the welfare state. So there can be a reduction in costs. It just may not be directly applicable to your organization. And there are things like environmental costs. Now, historically, we tended to work in silos, and we were very much focused on the cost implications to our own department, not even our own organization, our own department. We're now at a point where we probably factor in organizational benefit and potentially some health system benefit. But environmental and societal costs are probably still downplayed and probably don't have the weighting that they should. So it is very much about showing the reduction in cost to your organization, or to at least your ICB, your wider health economy. And when you do want to push forward a service agreement, you need to show that the improvement in quality is worth the costs. Okay, so the three elements I'm going to try and cover today for the rest of this talk is the NHS structure, a bit about how money flows through that system, and I'm going to touch upon payment systems, and that will be built upon by subsequent talks. So the NHS started in 1948. It was never an organised process. They nationalised the existing health systems that were already there. Okay, so in the first year, it ran out of money. So again, in its whole history, financing has been an issue. In 1962, they tried to be a bit more planned with the increase post-Second War increase in birth rates, population increases. They decided they needed to build a district general hospital for every 125,000 to 250,000 of the population. Okay, so for every 250,000 group of people, they wanted to build a hospital. They started, and they ran out of money. So it's this ongoing issue. So in 1974, you had the introduction of the health authority to try and be a bit more organised and try and coordinate and bridge the gap between hospitals and primary care. In 1990, they had this concept of the internal market. The internal market was, the idea behind it was that if you ask health organizations to compete with each other for work, then you will not only improve quality, you will reduce cost. The problem was that that worked for a bit at the times where money was in times of boom, essentially when funding was good, that was fine, and it probably worked to a degree. But then as soon as money became tight, so when you start getting recessions or when you start getting kind of austerity type things, you suddenly found that internal market didn't work, and you then had kind of race to the bottom in terms of you went for the cheapest option, which often sacrificed quality. We had the NHS plan in 2000 where they had a big driver for reducing waiting lists, and a lot of money was thrown into this payment by results system, which we'll talk about a bit later, where they drove targets and funding was related to those targets directly, which again worked in one aspect in terms of the elective side of things, didn't work in terms of urgent emergency care. The last really big major reforms to the NHS were in 2012. And I've called it Lansley reforms after the health secretary at the time who developed them, but mainly because the acts, the Health and Social Care Act, Health and Care Act, they all sound very similar. So the 2012 Act basically enshrined into law this idea of competition. It was something that when they were first thought about and devised, it probably made some sense in the vague notion of trying to make the NHS less political, more independent, have clinical decision-making, determining local priorities. So that all sounds like the right thing. Unfortunately, by the time it was implemented, the world had changed a little bit. So between the idea being developed, which is when the Conservatives were in opposition, to when they took power in 2010, you had the global financial crisis. And as with many things in the NHS, the idea might be sound, but the implementation probably didn't go to plan. And they started off with this 210 clinical commissioning groups, which meant that there was a lot of money being spent on a lot of admin. There was no power. It was almost too localized. And slowly, that's been reversed. So in 2022, the Health and Care Act did a couple of things. It basically reduced the number of CCGs, or got rid of CCGs to replace them with these ICB type entities. It abolished that need for competition. So services, when commissioners wanted to commission a service, they didn't have to put it out for tender. They could if they want, and they still can, but they didn't have to. So a lot of it was trying to tidy up the legislation. So the NHS in those 10 years had evolved, but was restricted by the legal framework that it sat in. And what the Health and Care Act primarily did was to tidy up that legislation to fit what was currently happening. Okay. And it's continuing to evolve. And with the potential, well, it will, NHS England will get abolished, but the exact mechanism by which that's going to happen is still not 100% clear. So this concept of integrated care. So the legislation basically introduces these two concepts: these integrated care board, which is the main body, and this integrated health and care partnership. I'm going to show you a animation in a second, which will try and explain those two concepts. It abolishes that need for competition and put in a duty, a requirement to collaborate, okay, between organisations. It allowed joint appointments and committees. And that's because historically, under the competition rules, you couldn't have joint appointments between two organisations that were theoretically competing for the same work. So now, by this duty to collaborate, you've got around that and allowed joint appointments and committees to allow closer collaboration between different health organisations. So the funding of the NHS is by the Department of Health and Social Care, which gets its funding from Parliament, and more specifically the spending review. The last spending review was last year, 2025, and then it's adjusted by the budget report, which happens in November. Okay, so that's the main fiscal events that determine how much money we get for healthcare. Healthcare is devolved, so the funding for Scotland, Northern Ireland and Wales is not via Department of Health and Social Care. It is by their own governmental framework. So the government of Scotland determines how much money of their income goes on health. And whilst it's called the Department of Health and Social Care is funded via the local authorities and not via Department of Health and Social Care. Okay, so if we factor all that in, so to think about, not going to get you to put it into a chat or anything, but just think about what you think the budgets of health, education and defence are in terms of the order, but also in terms of how much you think you'll get. So for the current financial year, so the one that's just coming to an end, the budget for health was about £215 billion. Okay, so that's greater than the GDP or the gross, the gross income of loads of countries. Okay, so that's how much we spent on health. Education gets 100 billion and defence gets 62 billion. So there's quite a lot of money going to health, a higher proportion of money going to health than ever before. So the implications of this, so the King's Fund did some work, and this is what they've come up with in terms of how much an increase we need every year to ensure parity of services, to maintain our services. And they've said essentially that a 1 to 2% increase in income, real terms, so if you factor in inflation, means that you end up with a kind of a very slow, but a decline in the quality of services. But you need 3 to 4 to kind of maintain those services and slowly grow them to some degree. Okay. On average, across the 70 years that NHS has been in existence, we're looking at 3.6% in real terms since it was produced in created in 1948. But that's not been consistent. So we've had 3% for a while. We had during the certain governments. We had in the 90s, late 90s, we had a lot more money to the NHS. We had a period of austerity after the financial crisis, and we've never really got back up to the kind of the 3% mark. The current government in the last spending review have committed to a real terms average growth rate of 3% for this parliament, but that may still change. But the main problem here is that spending on health as a percentage of all day-to-day public service spending is approaching nearly 50% of all public spending. Okay, which means that there are only 3 or 4 ways in which you can increase that. You can cut other services. Now, other services, public services have already been cut massively, and so that's probably not going to be a very good way of doing it. You can increase taxes, and so increase the amount of money that comes in. So that's one possibility. You can increase borrowing. That's another possibility, or you can grow the economy. So if your total income from taxation increases because the economy is growing, that's probably the best way. But it is very much variable and dependent on other factors, and different governments, depending on their outlook, will have different ways and different priorities in terms of how they do that. But that's what the options are. So if you look at how things have changed in terms of funding, so this is the amount of money the Department of Health and Social gets in total, so spending on health in total, of which a small amount, around 6 billion, gets spent by the Department of Health and Social Care, and we'll talk about what that's spent on in a second. The majority of it goes to NHS England currently, which is the orange bit, and then that's for day-to-day running of services. And then there's a small amount going into the grey area, which is the capital funding, which is your big purchase in building new hospitals. And why this year is different is because historically, whenever we've overspent in that orange bit, which we do regularly, we've taken money out of the grey bit, the capital funding. And the government want to try and stop doing that. They want to stop overspending on that orange bit so that we can actually build more things and maintain more things. So the capital funding is for maintenance as well. Okay. And what's happened is they've cut the blue bit. Okay, so the kind of expenditure by the Department of Health and Social Care has been cut. We try to maintain the expenditure in the orange. We're trying to protect the capital budgets. When any government of any denomination say they're going to protect or ring fence money for the NHS, they mean the orange bit, that NHS England funding. Often the blue and the grey get cut. So that blue bit, what did it actually fund? Well, it funds, apart from the NHS England, probably funds another 10 departments. Okay, and these are arms-length bodies. Some of them have national remits, so across all 3 of the devolved nations as well. Some of them are purely England-based. So you have the Medicines and Healthcare Products Regulatory Agency, which looks after, as it says, the healthcare and products, so medicines. So it's the equivalent of the FDA, the Federal Drugs Administration in America, probably the most popular one. The MHRA, claim to fame was it was the first regulatory organisation that approved the use of the COVID vaccine. The UK Health Security Agency was the new name for Public Health England. Public Health is an odd entity in that Department of Health and Social Care gives UK HSA, Health Security Agency, money for public health. That money then a lot of that money then goes to local authorities, because public health sits regionally within the local authorities and the councils. And then money comes back into the NHS for screening programs, immunisation programs, and other public health initiatives. Okay, so it's a bit of a weird circle. You've got NHS Blood and Transplant, the Business Services Authority, which looks after pensions and prescription charges, NHS Resolution, which is the litigation authority, and they have a patient safety role. So they administer the clinical negligence scheme for trust, which is that insurance system that organisations have in the NHS. And then the Counter Fraud Authority, which does what it says on the tin. Then you've got your commissions, which is NHS England. You've got NICE, National Institute for Health and Care Excellence, which look at value for money of medicines and devices and products. Historically, Health Education England and NHS Digital used to be funded by the Department of Health and Social Care, but they've been abolished and incorporated into NHS England. And you've got your regulators, the Care Quality Commission, and then some more niche ones, the Human Fertilisation and Embryology Authority, the Human Tissue Authority, the Health Research Authority, and the Health Services Safety Investigations Branch, which is the kind of the health services version of that airline investigation thing, which basically is looks at trends and looks at no blame culture. So it's about trying to look at a process and underlying problems in the system that led to incidents happening. So I'm going to play a video which will probably kind of illustrate some of these concepts. It will show some more detail. I'm going to probably stop it halfway through because the last bit probably doesn't apply anymore. This is a few years old now. We're working on a new animation which hopefully should be out by in the next few months. But yeah, so we'll start this. The numbers haven't been updated, but the concepts currently still apply. Ooh. I don't think I put a sound on here. Let me just.
Get rid of payments complexity with one frictionless system.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years to create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis.
Okay, so we're going to stop it there, and I'm going to talk a little bit about some of that stuff that they've talked about there. So the legislation tidied up the NHS England and merged NHS Improvement into NHS England. There's currently going to be some mergers of ICBs. There's currently 42. They're likely to be somewhere between 25 and 28 ICBs from April. I think it's about 26 or 27, depending on how the ones in London get merged together. So the idea is it's trying to simplify some of those processes, commissioning processes. so they can do it more regional way. And then what's going to happen is when NHS England disappears, its current functions are going to be split between the Department of Health and Social Care and the ICBs. So some will be delegated down, some will be taken up and absorbed into NHS Department of Health and Social Care. So the spending review, the last one is average 2.8 real terms increase in total health spending, but that commitment to have a 3% rise in NHS England funding. The idea is that capital investment will gradually increase to try and catch up with the maintenance backlog and deliver that new hospitals programme eventually. And NHS technology funding is going to double to 10 billion by 28-29. So that's the current plan. And it's all based on this 10-year plan, which is going to try and have 3 areas of focus and do various things to do that. The actual implementation process hasn't really been launched yet, so we still don't know how this is all going to work. So I'm going to very briefly cover payment systems in my last couple of minutes. There are 7 different ways in which an organisation can be paid for the services it provides. So I'm going to go through a bit of an overview of those 7 ways, and then touch on the aligned payment system, the current contract system, before going on to the next talk, which will give you some more detail about how commissioning works and how it's going to be changed the next couple of years. So there's something called block contract, which is a fixed amount to pay cover a specific range of services. It's decided at the beginning of the contract, and that it's fixed. It's traditionally used for services that are very difficult to measure activity, which traditionally things like community services. It can be for mental health to a degree. But it has been used in acute systems, so during the pandemic, but also pre-pandemic because of its predictability. You know how much money you're getting. You know the commissioners know how much money they're spending. So it's certainty that comes with block contracts. The problem is there's no incentive to do more work. As a clinician, I can tell whether we're on a block contract or an activity-based contract, particularly in winter, depending on the pressures I have to deliver my elective work or my department's elective work. So as a lead within a department, the pressures not to cancel, to try and think of all these different ways to maintain elective services, because that's what drives the income. When you've got an activity-based contract, is much stronger when you've got that system than when you had a block system where the income wasn't so dependent on getting that activity done. So the contract that you're on has clinical implications. Capitation is how a lot of it's the bulk of the funding in GP services. It is also how health ICBs and health boards in Scotland, Wales, and Northern Ireland get their funding. It is a weighted per capita, so per person of the population that's served by that provider. Okay. The differences are in that weighting. So the idea is you factor in things like demographics, so age range and deprivation indexes, and market forces. So things in Cornwall might be more expensive because of and London might be more expensive, partly because of rurality, partly because of the cost of living versus costs in other places. So you factor all of that in during your computation, in your weighting, and how you weight the population. And that's where the controversy is, how much weight different aspects should have. And so it's not the concept of capitation that's the issue. It's how it's weighted and how that's calculated that's the problem. Pathway of care is historic. It doesn't really apply anymore, but it keeps coming in and out of fashion, where you have a lead provider that manages the whole pathway. So they thought about it for things like joint replacement surgery. So from referral to joint school where you have counselling, you have patient optimization, you have the operation itself, and then you have the rehab afterwards. So all of that would be as part one pathway, and then the lead organisation can outsource essentially elements that are pathway to other people. It was used in hospital maternity services where you got payment for antenatal, payment for the actual birth, and then payment for postnatal, but it was not flexible enough to be able to cope with how changes in risk then get covered. So pay performance is a part of most contracts. It's a decreasing part of, or this particular sequence are not used very often in acute community and mental health. Currently, QOF, the GP Quality for Frameworks outcome framework, is still used in the GP contract. In acute community mental health services, they've started using something called best practice tariffs, which are slightly different as a way of improving quality, and that's because when sequence change every year, then you end up spending money on things that you're not getting the income from, and it can also be seen as be penalised for income because it just wasn't as flexible as it could be. Per diem is not used that much in this country anymore. It is used in some other parts of the world a lot more. It's a lump sum per patient, payment per patient per day of care. It works into some of the payment systems in hospitals for excess bed days, but not really used very much. The majority of payments are in particularly in the elective side and particularly in acute side is activity based. So the more activity you do, the more money you get, and it's basing on three components: the diagnosis, any treatments or procedures that were carried out, and patient characteristics or comorbidities. Okay, they all go into a kind of software program, and you part of the clinical coding program, which we'll talk about later on this afternoon. And it's probably the most used payment method across the world now. Certainly in a more economically developed world. Pass-through payments are where the cost of the service delivery is paid by the commissioning body, and it's more reserved for high-cost stuff. I'm very brief. I'm running over already, so I'm going to talk about this very briefly. But essentially, aligned payment center system is the current system is where there's a fixed element which covers all of mental health and community and ambulance services, but in the acute system it covers your urgent and emergency work and maternity work, but so that's a fixed bit, and any elective work is done on a case-based basis, so it's a blended payment system. And the final bit is if you don't achieve your best practice tariff or your sequins, if you're signed up to them, then you have their money taken away. Okay, so that's the basis of this. I'm going to move on to the next talk and then come back and answer any questions during the break because I've run over essentially. So next up, we've got an introduction to commissioning in the NHS by Donna Johnson, who's the Associate Director of Finance in Derby and Derbyshire ICB. I'm hoping she's here. I'm sorry for overrunning my talk, but I will try and make that time up in one of my following talks.
I am here. Thank you.
Great, thank you.
Good morning, everyone. Thank you for that introduction. So as just said, I am Donna Johnson. I'm the Associate Director of Finance at Derby and Derbyshire ICB. And as just been introduced in the previous presentation, ICBs are merging. So our ICB is merging with Nottinghamshire and Lincolnshire, which will make us one of the biggest in the country. So it is absolutely moving commissioning, and I will talk about that in my presentation. The way I have written the presentation to introduce commissioning is I've tried to do it from a clinical perspective, just so you can really understand how it affects your everyday working, but also how you can influence the decisions going forward. So I'm just going to share my presentation. Just bear with me. Hopefully everyone can see that. If you can't, somebody give me a wave. Wonderful, thank you very much. So this session is about understanding the commissioning system, and what I'm not going to tell you is how to turn you from a clinician into a commissioner. It really is an introduction, but commissioning shapes how care is organised, how it's accessed, how it's experienced, and as I said, I've really tried to have that focus on the clinical relevance, not just management theory. So, introduction to commissioning, the objectives of this session. So the NHS commissioning system has really evolved since its inception. I've only worked in the NHS since 2009, and there's been an awful lot of change, and I'm sure there was a lot of change before that, which I will touch on in the presentation as well. And it will continue to develop to meet the complex changes facing the NHS today, but also into the future. Commissioning is central to delivering the NHS triple aim, so I'll talk you through the triple aim. And the session will aim to provide a clear understanding of what commissioning is, how it's changing, the regulations and monitoring around commissioning, but also in care, and the importance of integration and working with others across healthcare and wider system partners. This next section is the foundations of NHS commissioning. So, commissioning matters because it links population need to service design. It has direct relevance to clinicians and patients, not just the organisations that provide healthcare or carry out planning. Commissioning in the NHS. So what is the meaning and what is the clinical relevance? So commissioning in the NHS really refers to the systematic process of assessing the health needs of the population, planning the services around those needs, securing that provision in whatever setting is deemed most appropriate, but also monitoring the outcomes. So for clinicians, commissioning is, it might be seen as a management function, but actually it is a powerful mechanism that shapes everyday clinical practice and what patients experience. It determines which services are available locally, how care pathways are structured, which providers patients can access. So, for example, the availability of community cardiology clinics or rapid diagnostic centres or enhanced mental health services. They're probably the result of commissioning decisions that have been informed by the population need over a number of years, and also the clinical evidence to support those. Commissioning does affect the referral criteria, the thresholds for intervention, and the models of multidisciplinary working, all which influence clinical workflows and professional judgment. And no doubt you see these day in, day out. From a patient perspective, commissioning really does impact on equity, access, but also the outcomes. So decisions about prioritising prevention, early intervention, or specialist care, they all influence waiting times, the continuity of care, and health inequalities. And health inequalities have been a really big focus in the NHS for the last few years, actually, and rightly so. So for clinicians, understanding commissioning helps explain why certain pathways exist, and why resources may be constrained in specific areas. It does provide a framework, though, for influencing change, and this is what's really important, what I'm really going to try and talk you through today, because clinicians are so well placed to identify unmet need, identify inefficiencies and variations in care quality. So by engaging with commissioning processes, clinicians can really advocate for services that better reflect real world clinical complexity and patient needs. Importantly, commissioning links clinical quality with finite resources. So, and this does bring it back to finance, which I haven't touched on much, but the NHS does operate within a very finite fixed budget, meaning the choices must be made about what to fund, where we want to expand services, or when we want to redesign. Commissioning really does seek to balance the benefits at a population level with safety and effectiveness for individual patients. So when clinicians understand this balance, then they're better equipped to contribute to that service redesign and support value-based care, explain decisions to patients transparently, because sometimes it doesn't always seem fair the way a patient perhaps receives care. Ultimately, commissioning provides the structural context in which clinical care is delivered, and making it essential knowledge for clinicians seeking to improve care beyond the bedside. The final point on this slide is around change. Commissioning will also use its links and leadership to drive change through levers, which has just been mentioned in the previous presentation. You know, some of those financial incentives and contractual management, such as your QOF and your sequin. So in summary, commissioning it's assessing the need, planning the services, securing that provision and monitoring the outcomes. Why commissioning matters to clinicians and patients. So commissioning matters to clinicians because it fundamentally shapes the environment in which they deliver care. It determines what services exist, how pathways are organised, and what standards define good care at scale. So for instance, whether patients with suspected cancer can access one-stop diagnostic clinics, or whether frail older adults receive proactive community support. It's all driven by commissioning priorities. These decisions influence clinical autonomy indirectly by setting the parameters within which the professional judgment is exercised. And clinicians often experience it through that referral criteria and service specifications, performance metrics. And I appreciate sometimes you might feel that hinders high quality care. It is there to support, but can hinder. And that's where clinician involvement is really important to improve those aspects. So for patients, commissioning directly affects access, continuity, and outcomes. Well-designed commissioning can reduce variation in what patients receive, but conversely, poorly aligned commissioning can result in fragmented services, repeated assessments, or gaps between primary, secondary, community care. And patients may not see the commissioning process itself, but of course they do experience the consequences of that through waiting times, eligibility thresholds, and the availability of local services. Commissioning does play a vital role in addressing health inequalities. So by analysing that population data and outcomes, commissioners can target interventions at groups with the poorest health or highest unmet need, such as deprived communities or people with long-term conditions. Clinicians who you understand the lived reality of these patients, and it's absolute essential contributors to shaping the priorities of the future. Also, commissioning influences how quality is defined and measured, including patient-reported outcomes and safety indicators. So when clinicians engage with commissioning discussions, they can help ensure that measures reflect meaningful clinical and patient-centred outcomes, rather than just narrow process targets. In this way, commissioning becomes a shared endeavour that aligns system goals with professional values and patient needs. And if I just talk you through a bit of an example, so a historic problem where patients suspected with heart failure would be referred to see a cardiologist, have a number of outpatient appointments, have a echocardiogram, and it just meant there were lots of referrals, lots of appointments. So there's of course long waits for diagnostics and specialist review. So not a great patient experience. So the solution was to introduce a clear integrated care pathway, starting in primary care, where the GP would do look at clinical criteria and do testing, and have that direct access to, rather than refer to cardiologists, refer to an echocardiography itself, and just bypassing unnecessary outpatient appointments. And then providing coordinated treatment for the patient across community and secondary care. So what's the benefits in that? So the patient, much faster diagnosis, far fewer appointments, clearer plan, and just generally improved experience from a clinician point of view. You've got that early intervention, reduced risk, clearer thresholds and responsibility. And from an ICB, from a commissioner perspective, it reduces that outpatient demand, so you've got fewer avoidable admissions, better use of diagnostics, and more consistent outcomes. So it really can work. So how commissioning works. I've just talked about what commissioning is. I'm now going to move on to how it works, and the processes that we go through. So what commissioning means in clinical practice. So in practical terms, commissioning means making structured decisions, and I've touched on some of this, about what care is needed and which patients, delivered by whom, and to what standard. And so from a clinical perspective, this just translates into the defined pathways, the service specification and outcome measures that guide everyday practice. Another couple of examples, a diabetes pathway may specify eligibility for structured education, access to multidisciplinary reviews, and thresholds for specialist referral. And these specifications are intended to promote consistency, safety, and value, while still allowing clinicians to tailor care to individual circumstances. Commissioning also involves assessing evidence and balancing trade-offs. So decisions are informed by clinical guidelines, population health data, patient feedback, and financial constraints. Clinicians contribute expertise on what interventions are effective, feasible, and acceptable in real-world settings. And their insight is particularly valuable when guidelines do not fully reflect local context or complex comorbidities. And so without that clinical input, commissioning risks just producing pathways that are theoretically sound, but operationally, completely impractical. Another core element of commissioning is defining standards and outcomes. This includes quality indicators such as reduced emergency admissions, improved recovery, or better patient experience. For clinicians, these outcomes can align care with purpose, but they can feel burdensome if poorly designed. Meaningful commissioning uses outcomes that reflect what matters clinically and to patients, rather than just excessive process measures. Commissioning in clinical practice should be seen as a structured attempt to support high quality, equitable care across the population, and relying on clinicians to bridge strategic intent and frontline delivery. The commissioning cycle. From need to improvement. So we've looked at the needs, priorities, design, monitoring, and then improvement. And clinicians are crucial at every stage of that. The cycle really does provide a continuous framework for planning, delivering, and improving services. So it does begin with that understanding population health needs, and this is probably where commissioning is a little bit different to frontline provider, where there's that focus on the population, not just the patients that are part of our day-to-day care. So we look at that population health needs, so disease prevalence, service utilisation, outcomes, inequalities. And this stage really relies heavily on data analysis, but benefits greatly from clinical interpretation, actually, as clinicians can really contextualise patterns and identify hidden drivers of demand. The next step in the cycle involves agreeing the priorities and desired outcomes, so balancing that national policy, local need and available resources. So once priorities are set, services and care pathways are designed or redesigned. And this is where clinical leadership is particularly important, ensuring that pathways reflect best practice, patient flow and safety considerations. Commissioning then moves to securing the services, which may involve the contracts with providers or agreements within the NHS. So clear service specifications set expectations around access, quality, and outcomes. And then the final part of the slide, so monitoring. Monitoring and quality assurance are, of course, essential components of the cycle. And I think from a commissioning point of view, this is perhaps an area we recognise for development. I think often we'll identify the services and put them in place, and then the monitoring is not always as perhaps robust as we would like. So activity data, outcome measures, patient feedback, they'll be used to assess whether services are delivering intended benefits. So when there's gaps or unintended consequences, the cycle might progress to improvement and redesign. So for clinicians, the commissioning cycle, I suppose, mirrors the clinical quality improvement. So that identifying a problem and planning a clear aim, test the change on a small scale, so it might be a clinic or a ward, review the results against expectations, and decide whether to adopt the change, adapt or abandon. That final one, actually, abandon, I think as commissioners, that we really struggle with stopping services. We've got commissioners who are really, really passionate about the area of healthcare that they work in. So coming up with new ideas and new possibilities of care for patients, but we do struggle with the what's not valuable, what should we stop, and as we know, we have got finite resources to work with. So strategic aims and system change. So here I'm going to look at the NHS triple aim and commissioning decisions, looking at that historic fragmentation that was part of commissioning, and then moving on to now these integrated care systems and how they work. The NHS triple aim and commissioning decisions. So the NHS triple aim provides a strategic framework for commissioning. And the framework involves improving population health, delivering high quality and safe care, and ensuring sustainable use of resources. So commissioning decisions are expected to balance these three aims, recognising that if you focus on one in isolation, it can obviously undermine the others. So, for example, investing in preventative services such as smoking cessation or falls prevention may reduce long-term demand on acute services, which ultimately improves population health and sustainability at the same time. However, the NHS does have finite resources. So the uncomfortable truth is that choosing to invest in one area means choosing not to invest elsewhere, even if both are clinically worthwhile. And this is why clinical voices matter. Otherwise, decisions default to finance, activity or national pressure rather than patient benefit. And we also have that short-term view in the NHS. There's resources are really tight, and there's often a real focus to deliver that current year financial position. And when you're doing that, you're not looking longer term. So whilst we know the 10-year plan wants us to invest more in prevention, which in a few years' time, we will really see a financial benefit of that. But ultimately, we've got to balance this year. So how do you find the money to invest in such prevention? Because you're not going to reap the benefits in the same period. So it is really challenging to get this right. For clinicians, the triple aim really explains many system level decisions that may initially appear financially driven. Resource sustainability is not about cost cutting alone, but about maximising value and reducing low benefit interventions. So high quality care involves safety, effectiveness and patient experience, all of which are shaped by commission standards and outcomes. Population health broadens the clinical remit beyond individual encounters to consider upstream determinants of illness and those health inequalities. So understanding the triple aim can help clinicians engage constructively with commissioning discussions. So framing clinical innovations in terms of a system-wide benefit. For instance, a proposal for expanded community respiratory services can be articulated in terms of reduced admissions, improved patient quality of life, and better use of resources. So aligning clinical arguments with the triple aim increases their impact and supports that collaborative decision making across the system. From fragmentation to integrated care systems. So how has it all changed in commissioning? The future really is about pathways and population. So historically, commissioning in the NHS was about organisational boundaries and it did create fragmented services. So in the 90s, commissioners were introduced with a clear split from providers in order to have a clear planning function over here and a clear healthcare function over here, and they were very much separate delivery models. And then CCGs were created in 2013. And that really looked to have clinicians drive in planning in order to better reflect local patient needs. So clinicians were very much part of the board in CCGs. But these historic models, there's still that separate planning and separate healthcare did often lead to just disjointed patient journeys, duplication, and cost shifting between providers. And that's what the move to integrated care system looks to change. It is a fundamental shift, with commissioning increasingly focused on pathways, population, and partnerships rather than individual organisations. So, in Derbyshire, we work with our mental health provider, our community provider, and our acute providers, but also, of course, primary care and local authorities to bring that all together. So we're all working with the same goals. So it's the ICB model is deliberately less local and more strategic CCGs, and that is a feature. It's not a flaw, but it does feels very different to providers. Integrated care aims to coordinate the services across all primary, community, secondary, social care, and particularly for people with complex or long-term conditions. Commissioning within IC integrated care systems prioritises that collaboration, shared outcomes and prevention. And for clinicians, this means greater emphasis on multidisciplinary workings, shared care models, system-wide accountability for outcomes. Commissioning decisions are increasingly made with input from a broad range of partners now, and that's great. And that will include your local authorities and voluntary sector organisations as well. While integration offers significant benefit, it does require a cultural change. It is very, very different. And clinicians may need to think beyond their organisational loyalty and consider the whole pathway of care. Commissioning supports this shift by aligning incentives and outcomes across settings. So understanding this evolution helps the clinicians navigate new roles and influence emerging models of care within integrated systems. It all sounds idyllic, but we have to recognise that ICBs and ICSs are still very much in their infancy. the frequent structural change that we see in the NHS, it can weaken trust, and it's a distraction, you know, from the core purpose of improving patient healthcare. Structures change, but the NHS purpose doesn't. Patients don't experience organisation; they experience pathways, don't they? Governance, regulation, and professional practice. So I'm going to talk about what is the role of integrated care boards in commissioning, regulation, quality monitoring, and clinical autonomy. And governance, you know, it exists to support safe and equitable care. It's not anti-clinical, and I do like the phrase governance. Governance is our friend. So the role of integrated care boards in commissioning. So ICBs are responsible for commissioning most NHS services at a local level. Their role includes setting clinical priorities, allocating resources, and ensuring that services meet quality and safety standards. ICBs work in partnership with NHS providers, local authorities, and other stakeholders to address population health needs and reduce inequalities. Commissioning decisions are also shaped by national policy, political priorities, and public accountability, sometimes creating tension with local clinical priorities, I would say. So for clinicians, ICBs are a key interface between that clinical insight and system decision making. And many ICBs include clinical leaders who help shape those priorities and service design, which is great. Understanding how ICBs operate enables clinicians to navigate that decision-making process, influence commissioning intentions, but also escalate concerns about quality or access. ICBs must balance the competing demands. That's one of the roles, and making transparent governance and clinically informed decisions. It's essential. ICBs are also accountable for that financial sustainability and performance against national objectives, and this really does create tension between ambition and affordability. So clinicians who understand these pressures are better positioned to propose realistic high impact changes. Engagement with ICBs allows clinical perspectives to inform strategic plans, ensuring that commissioning decisions remain grounded in patient care, about the patient and the professional standards. It may come across as activity ceilings, but you know, it does influence that referral criteria to get that balance right. Regulation, quality monitoring, and clinical autonomy. So why does regulation exist? Regulation and monitoring are integral to commissioning, ensuring that services are safe, effective, and deliver agreed outcomes. This will include your quality standards, performance metrics, contractual requirements, and that external oversight, which can be quite challenging, I appreciate. For clinicians, these mechanisms can really feel restrictive, but they are intended to protect patients and promote consistent standards of care. And so I would say protect clinicians as well. Commissioning defines pathways and expectations, while clinical autonomy operates within these boundaries. Professional judgment does really remain central, particularly in complex or unusual cases. But it is exercised in the context of system-wide agreements, and tension can arise when rigid specifications conflict with individual patient needs. So that constructive dialogue between commissioners and clinicians is really essential to refine pathways and allow that appropriate flexibility. When clinicians engage with quality monitoring, they can help ensure that measures reflect meaningful aspects of care, highlighting unintended consequences or perverse incentives supports more intelligent commissioning. So feedback is great. Ultimately, effective regulation should enable and not hinder good clinical practice by creating those conditions in which high quality care can flourish safely and equitably. I'm conscious of time, so I've only got a couple more slides left. Clinical influence and future improvement. So this section focuses on where clinicians add the greatest value to commissioning, the key messages and some practical takeaways as well. And I would love to hear from some of you that have actively worked with commissioners to influence services and drive improvement. Where clinicians add the greatest value. So clinicians, you bring that frontline insight that the system cannot see from data alone. Commissioners rely on clinicians to identify, unwarranted variation, safety risks, pressures that are emerging before they show up in any performance data. Variation's not automatically bad, but unexplained variation is well, clinicians help just distinguish that. The legitimate clinical flexibility, variation that reflects inefficiency, inequity, or outdated practice. Clinicians define what value actually means in practice as well. It's not just activity or cost, is it? It's about patient benefit, outcomes that really matter, and of course experience and safety. As I've said, stopping services is something I think we struggle with. So challenge that low value care as a clinical leader. Commissioning is not about just introducing new services, it's about stopping or redesigning things that no longer help patients. And this influence goes beyond individual organisations, through clinical networks, pathway redesigns, on pathway designs and system leadership roles. Clinicians shape services across the whole system, not just their own setting. I appreciate that clinicians often see system problems before they appear in performance data, and that's why that collaboration is so important. So let's not wait for the data. So very last slide. So if nothing else has gone in today, some of the key messages to take away from this presentation, I hope, is that commissioning is not separate from clinical care, but is a critical enabler of it. And understanding commissioning helps explain why services are configured and provides opportunities to influence improvement. Clinicians should see a commissioning as a cycle aligned with quality improvement and driven by experience, outcomes, patient need. So practical takeaways include recognising the importance of population health perspectives, engaging with ICBs and clinical networks, and using data alongside clinical insight to advocate for change. Awareness of the NHS AAA helps frame clinical proposals in ways that resonate with system leaders. Clinicians should also feel confident in raising concerns about quality, safety, or unintended consequences of commissioning decisions. By engaging constructively with commissioning, clinicians can help create conditions that support high quality, equitable and sustainable care. And this engagement just strengthens the link between frontline practice and system strategy, ultimately benefiting both patients and professionals. And that's why we're all here, aren't we? We're all here for patients. So commissioning, when understood and shaped collaboratively, it becomes a powerful tool for delivering better care at scale. I've gone way over my time, so if people want to put questions in the chat, or I can perhaps do them at the break as well. I can do that. Happy to do that. Thank you.
Thanks, Donna. Any questions for either myself or Donna? You didn't go over, I went over, so you started later, so you're fine. You went to time. I was I was the cause of the delay. Any questions? We'll give it 2-3 minutes for any questions, and then we'll take a 10-minute kind of refreshment break before we come back and do procurement. I'm going to go after during the break. I'll go away for a few minutes and then come back. And if you have any questions, I'm still happy to take them in the break as well. So, so how will integrated health organisations compare to the current ICBs?
Oh yeah, I can see that in the chat. How will integrated health organisations compare to the current ICBs? When we say integrated health organisations, are we talking the new clustered organisations? Because ICBs will definitely continue to exist into the future, for the foreseeable future, certainly until we get another government. Yes, the new clusters. The new clusters were all part of the government's drive really to save money. So we have one board now in our cluster rather than three. There should absolutely still be that local population need understanding, and we will have place and neighbourhood teams that will still focus on that, and still focus on that collaborative working with our providers across the systems, so across the providers in Derbyshire, Lincolnshire and Nottinghamshire, to shape the pathways and the population need and care. So the bigger clusters, I'm not sure we'll see a change. I think it will, as I said, they're still in their infancy, and I think they will still be on that strategic path for population need, and balancing that with quality and finite resources. I think the shaping was really about more of a national cost cutting, running cost exercise.
I think it was to do with a lot of it was to do with the sheer number of CCGs they had, and the fact that they couldn't actually make any contractual decisions because they weren't able to do the contracts at CCG level. They had to do it with multiple CCGs. So you basically end up with 5 or 6 CCGs kind of joining together, and then each one taking responsibility for a different aspect of a contract with one of the health provider organizations. And what they've done now is one of the reasons for clustering a bit more is so that when you take on the delegated responsibilities of those specialized services, you can do it for a bigger population, and those contracts basically make it easier for contract negotiations at scale, rather than every small ICB, the 42, having to discuss those things at quite low local level for smaller populations. That's probably the main driver. How it all actually works out, nobody really knows until we know the details. The other question in the chat is about layperson or patient representation in decision making at ICB level.
Yeah, so the process is, we have tiers of governance considering how we might change patient care, and there'll very much be clinical representation in there, laypersons in there, before it goes as a formal business case for approval to the executive team. And as part of that whole consideration before it gets there, it really is about balancing that population health need, the clinical benefit, inequality impact, and sustainability. But whenever we do new services, the vast majority of time we will have to do a patient consultation, so very much getting patients involved in that decision making, and very much clinicians as well. So absolutely there is representation from across a number of experiences and experts before decisions are finally made.
Thank you. Thanks, Donna. I'm gonna push on to have a break now. If you feel free to keep asking questions in the chat, and then we'll start the talks back about 11:10, but have a break, and I'll start answering questions a few minutes before that, just to cover anything from the first talk as well. Okay, so oh. Do you want to answer this last one, Donna, before you go, and then about change culture and collaborative working.
Oh,
That's a big topic, but
that is a challenging one. So how do you change culture? Well, I mean, it absolutely takes time, doesn't it? And how do you get more collaborative working? I have seen a real change over the last few years, actually. There is a lot more collaboration between commissioners and providers. But it's going to take time. You know, there's lots more regular catch-ups to understand what's going on the ground. There's lots more data analysis, which I touched on in the presentation, which is shared amongst us all. We're sharing our problems, we're sharing our woes, we're sharing our ideas. We've got program management officers now that look at things, transformation across the whole system. So thinking about the end result rather than that individual organisation. But it's still early days. It will take time. I really hope there'll not be another change in the way commissioning works, because it does often feel like we get into the just as we're getting into the swing, there's a change. But yeah, culture is a challenging one. But I would say is, which I've tried to say throughout my presentation, is really engage with commissioners as clinicians. It's so important, and I think if everybody gets on that journey, it does really help change that whole culture. Getting involved in those networks.
Thank you. Right, I'm going to draw it close there. So I have 10 minutes, so come back at 11:15. I said I'll be here a few minutes early if you have any questions, but have a break. We'll go on to procurement. It's me again doing procurement to fill in for another speaker. So I'll see you in 10 minutes. Thanks, Donna. Thanks again. Okay, so welcome back. I'll be talking to you about very much a basic introduction to procurement in the NHS. So as you may have remembered from this morning, I'm not a procurement team member. I'm an anaesthetist who works in Leicester. I'm filling in for another speaker. These are my slides, but so what we're going to focus on is very much the basics of what procurement is, how it works, and some of the methods by which you can buy goods into your organisation. And we'll talk about some pros and cons. I've got about 20 minutes to cover this, and hopefully it'll give you some insight into how it all works, what the kind of pitfalls are, and the timelines involved. So procurement is simply the process of obtaining any goods or services. It can be buying it, can be hiring it, can be leasing it, can be borrowing it. And in the NHS, we do all of the above. I'm not specifically going to talk about commissioning services because that's a slightly different thing, there's a slightly different take on it, but we're going to mostly focus on goods and services such as facilities rather than services as in clinical services. Okay. So painters, decorators, that kind of stuff rather than clinical services. Okay. So that's what we're going to be focusing on in terms of procurement. So the NHS spends about £33 billion on goods and services every year. And it's estimated that about £1 billion is lost to inefficiencies. And by that, I mean, if you compared trusts in a similar region, so that the cost of delivery and all that kind of stuff should be similar, the amount of money they pay for something simple like gloves can vary massively. It may not vary massively in terms of the individual price of a box of gloves, but if you look at how much we buy and the quantity and volume of that, then that can be a big issue. It is actually what the getting it right first time process was all about originally. It's about that unwarranted variation, and it started off in terms of goods and clinical equipment, and is then shifted to the general service provision as well. Okay. So it's really important to understand what procurement is, how we want to get the goods, the bits of kit that we need, and the process by which we can get good value for money doing so. So there are actually quite a lot of regulations and rules around procurement, and which is why it's really important when you go down a procurement kind of thing, especially for big bits of kit, that you get your procurement teams involved. So until recently, it was the public contracts regulations that kind of set all the rules. But as of last year, we had a procurement bill which is supposed to simplify it and try and assist particularly small and medium businesses to be able to actually get involved in procurement, but public service procurement. So this is not, the rules aren't specific to the NHS, but they are to do with procurement as a whole. Okay. The provider selection regime is specifically to do with the procurement health services, and it basically is more related to that exclusion for competition that's required for other procurement, other commissioning and tendering exercises. So it means that you don't have to, like I said earlier, you don't have to put services out for tender if you want to commission a new service. Okay, so that's what that little bit of regulation is to do with. I'm not going to go into loads of detail about the rules and regulations. It is all it's quite complicated, and essentially the rules that determine what you have to do is determined by how much money you're spending. Okay, so the value of the contract determines the rules that apply. And there are national rules, and there'll be local rules. Your local rules for what you need to do as part of your procurement process are normally in your standing financial instructions. So there's a document published by the finance teams called your standing financial instructions, and that tells you what your rules are. This is an example of one that I found online from an acute hospital trust. Okay, and this is their standing financial limits. Okay, so the UK PCR is the public contracts regulations limit. It's currently set at about £215,000, I think it is. So any contracts that are going to be more than that have to go through some sort of tendering process, external tendering process. Okay, so that's the key. So when you're looking to procure something, you have to factor in the whole life costs of that bit of equipment. So that includes any upfront costs, so the start costs, and that can be the planning, the installation. Okay, so one of the things that's massively often excluded from when you're thinking about it is installation costs. So in our organization, they had an idea, good or bad, depends on what your perspective is, about using some NHS England money that was specific for technology advances. So they wanted to use AI cameras of some sort to look at how productivity in theatres. And so the money costs covered the purchasing of the cameras that was available, but what they hadn't factored in was the cost of installation, and ultimately it's what scuppered the deal because the installation costs were so high, partly because in the hospitals I work in, our infrastructures are poor, and it would require massive changes to our cabling as well, internet cabling, and then so the whole thing got kiboshed, which pleased a lot of people, but ultimately it wasn't a great thing because they didn't factor in all the costs, including installation costs. Okay. So you have your upfront costs, and then you have to use whatever the contract length is. You've got to then factor in your maintenance costs. So what kind of process is there for repairs or replacements or warranties, and then your operational costs, so your consumables, and if it is a high energy consuming device, your energy costs, and then your disposal costs at the end. So what you can do with it at the end, is the company going to take it back and dispose of it for you? You're going to have to dispose of it, which can, if it's a big bit of kit, can cost a lot of money. Okay. So when you're trying to work out how much it's going to cost you to do this something, you've got to think of the whole life cost of it. And that will be the value of the contract. Okay. Increasing, so traditional procurement is that you have your your specification list, and you decide these are the criteria that I want. Okay, these are the criteria that you need, and then what you then end up doing is not really factoring anything else and just going for the lowest cost price. Okay. The point of value-based procurement is that you factor in the clinical consequences of the different things you're buying, okay? Not just purely the cost of it. Okay, you look at outcomes, you look at patient satisfaction, patient experience, and you use that as part of your decision-making process. Okay? So you might find that in theatres, you might find that we used to have a bit of kit that we can use small to check how paralyzed somebody is during an anesthetic. Okay. And that's a small little box. It costs £5–10, easy to break, easy to get lost. Okay. There's a more expensive bit of kit which is built into the anesthetic machine. It gives you quantitative, so it gives you a number as to the degree of paralysis the patient has, but it's about 10 times more expensive. But one, you don't have to buy as many of them because you don't get them lost because they're built into the anesthetic machines. Two, there's good evidence that suggests that inadequate reversal of muscle relaxation leads to higher longer ICU stays, poor patient experiences. It can cause problems and longer hospital stays. So if you factor all of that in, it makes it much more worthwhile, even though it's 10 times the price. Okay, so value-based procurement is about using the clinical mechanisms when you're deciding whether you procure something. In urology, there's a similar thing. So the standard TURP kit is much cheaper than the newer way of doing prostate operations, which is a Urolift. Okay, the Urolift is again probably 5–10 times more expensive than it costs in the standard way of doing it. But the Urolift procedure can be done as a day case, whereas the TURP often needs a 2-day, 3-day admission. The complication rates after TURP are much higher than the Urolift. So again, the benefit, if you factor in the clinical side of things and their clinical costs, have a massive impact. So that's what the purpose of value-based procurement is all about. And that's why it is ingrained and inbuilt into the procurement rules that we should be factoring and using value-based procurement for how we buy goods and services in the NHS. Okay, so there are procurement practice. So there are different ways of buying things. Okay, the one that's used the smallest is directly from individual suppliers. Okay, so that's actually it's almost the wrong way around. The most common way of buying stuff is through the NHS supply chain. So they are things that has already been bought essentially, and you're buying stuff via them. And so if things are available through the NHS supply chain, as long as your department agrees, there's no procurement process. You just order it. So it's good for small cost items, so syringes, needles, small bits of kit that you can order different versions of and update versions or whatever it is you want. You can order that through the NHS supply chain, providing your organization approves of it. Okay, so if you as a department or as a group agree, and whoever the budget holders agrees to buy it, they can buy it. It's not an issue. Okay, because it's already been processed and bought. To some places they have procurement to collaboratives, so some organizations group together and do a similar thing, but they bulk buy, and then you're kind of limited to what you buy, what you can buy by your procurement collaborative. So if I think there's an East of England procurement collaborative, so most of purchasing for high volume, small cost items is through that. Okay, so that's probably the main way for smaller items. The national framework agreements and contracts, and then the frameworks are for bigger items, essentially. Okay, and it can be anything from fridges to bits of specific specialist bits of kit. And the national framework agreements they're companies that have been vetted and approved for use. Okay, so essentially you can't just go to Temu and order stuff. You have to go through these framework agreements, and it means that they are approved. They've gone through the regulatory and legal frameworks to deliver product into the NHS. And if you go through a framework agreement or a framework process, you have two ways of doing it. You can directly award it. So you can say, we want that thing, and you can pick it and negotiate and do that. Or you can have mini competition. Okay. So the direct award framework is the product specification matches something that's already on the live framework. And there'll be a threshold that organizations have for that framework. Okay. Because the contract is effectively already in place, you can get your kit, you can get your stuff within days to weeks. Okay, but because the specifications are is fixed, the kind of clinical input is limited for that. Okay, so you get your kit really well, and it's a bit like supply chain in many ways, but actually for kit that you want some sort of clinical input for, you kind of have a mini competition. And that's what we did for our anaesthetic machine. So, we buy anaesthetic machines once every 10 to 15 years. They're the key bit of kit that we use. So it's quite important for us to make sure we get the right ones, and we want clinical input, and we want to have a way of doing it. But we don't want to go through an open tender competitive procurement process, because that'll take months and years. Okay, so this way we kind of we select several companies off the framework that are framework approved, and then we have a little mini competition within the framework, and we then specify what we want, and then you can choose which one you want. So the framework pre-qualifies them. So it's like getting drugs off the BNF. So if it's in the BNF, so the framework is like the BNF. It's the British National Formulary. It tells you what drugs have been approved, what's actually available. Your organisational formulary will tell you what you can buy directly. And if you want something that's not on your organisation formulary, you then have to ask and get it approved, and providing it's in the BNF. If it's not in the BNF, then that's a much bigger and more roundabout way of doing it. You've got to get a drug that's via different means, because actually it might be off license, and there's a whole load of other admin and paperwork that needs to be done to get that. Okay, so we did that. We did a mini competition. We evaluated, we chose which one we wanted. We then set our specifications based on that, and then we can choose which one wins, essentially. We have to factor in the price into it as well. So it's not we want that one and there's no discussion. We then also have to factor in, and it's a discussion between procurement, finance, and the clinical teams as to which one gets selected. And when we chose, we got it down to 2, and then the finance basically determined which one of the 2 that we actually bought. And the final one is that open tender. Okay, so particularly if you're getting something that's really high volume, so the most recent one I've been involved in is for interpretation and translation services for the whole of our organisation. So if it's the purchase value exceeds the framework thresholds, or it meets the public contract regulations amount, which is 213,000, or it needs something very specific, you basically then open it up to anybody to bid for it. So you basically put your specifications out, and anybody who can and wants to meet that specification and deliver those products can submit into it. Okay. And it can mean there's it can take 18 months to get that process sorted. Because you need to do a needs assessment, then you do a market engagement process, you do your specification writing, you've got to then you've got to basically advertise it, and then there's a specific portal where the website that basically all these tenders go to. Then you have your evaluation period where clinicians and other people then evaluate all the tenders that come in to make sure they meet the criteria. And then you've got this point, there's like a standstill period where before the contract can actually, so once you kind of rank them and awarded, decided to choose one particular company, then there's a kind of standstill period where the other companies get feedback, and they can, if you're not careful and are very not very specific with your specifications, can appeal against your decision, which can really kibosh the whole process. And so when you're writing your service specification as clinicians or operations teams, you've got to be really careful and really specific at what exactly you want. Okay. And then when you're evaluating, you've got to be really specific on why you've chosen one over the other, particularly as these are high value contracts. It can really delay things even more, and you can have standstill periods, you have appeals, and you have to have meetings again. It's so time consuming, and it can delay the contract awarding for months, and then before you can actually then get it actually in place. So I think it's taken 2 or 3 years for us to be able to get our interpretation translation tender process completed because of that. We're a big organisation, so it's a multi-million-pound contract. So you've got to be really careful, particularly with the open tender competitive procurement processes, because there is a lot of scope, particularly if it's a high value one, for people for companies to appeal your process unless it's watertight. The benefits of the procurement process, the supply chain, is it covers 80% of English procurement. It allows bulk purchasing to allow better prices. So in theory, we get the best possible pricing. The supply chain is based on different capital, they call them towers. So different companies manage it. So if you want to influence what's in the supply chain process, you've got to contact one of these companies, organizations, to be involved in their procurement of kit. So they're the ones that buy things on behalf of the NHS, and then they sort it out. So these are the category towers. There's 11 of them. As I said, framework agreements, pre-approved list, usually for high value contracts. So in summary, basically what we want to do is your clinicians want or need a product. Is there a like for like already? So is it very simple and straightforward? If not, then you've got to do a product evaluation or an options appraisal. And particularly if it's not on a framework or not on the funding is not easily available, then you may need a business case. So if you're not replacing something but a better version of it, you may need a business case to prove that there's a clinical benefit for it. If there is already, if it is a like-for-like replacement, is there already a contract in place? Because if you are tied into a contract, then you have to go with that company and source it from them. If not, then if there is, then you have to check when the contract expires, and if there's not, then you can initiate a trial or do a competitive open procurement and then initiate a switch. Okay. We talked about direct awards, mini competitions, and that's my very, very quick overview into NHS procurement. Any questions on that? As I said, it's a very basic version of it. Is that clear? That's stunned silence. I'm not sure. Okay. But I have caught up on time, which is quite important. Okay. So the criteria, you mean on the framework agreement? So companies can apply to join a framework. So framework agreements normally run for about 3 or 5 years. There's normally a particular clinical kit. There's normally a clinical advisor group that determine the specifications to get onto that. And then they have to clear certain regulatory legal frameworks essentially. So you've got to be you've got to have got all your kind of safety marks. You've got to have been approved by NICE and the MHRA, depending on what the criteria is, what the kit is. You've got to have passed all the safety standards, because the safety standards for use in a public environment is different for use in domestics, in a domestic environment. So you end up trying. The companies have that. I mean, the paperwork is probably hundreds and hundreds of pages of paperwork that companies have to complete to get onto these framework agreements, which is often why the cost of buying a kettle for the NHS is 5 times as much as buying it from Currys. The regulatory requirements are much higher. And they've got to proven that they are safe, they meet the standards, all the standards. They can be used for high volume work. So a kettle at home might be used for a few times a day. A kettle in a workplace or in a hospital is almost constantly used, which is why they try not to use kettles and use big water tanks. But there are lots of criteria that have to be met. You've got to have safe supplies in terms of supply chain maintenance. You've got to meet lots of ethical procurement requirements as well. So you've got to make sure that they're not. You've got to do the best of your ability to make sure that there's no kind of enforced labour, as best in terms of working standards and working conditions are as best as possible. So there is so many barriers and hoops that those companies have to get through, and so it costs them a lot of money to get onto those procurement frameworks. So they end up they obviously pass them on to us as NHS organisations. Okay. Any other questions, very briefly? I'll be in and out for the next couple of sessions, but I'm doing the clinical coding session and the business cases session later on. So if you do have any questions, I can come back and answer them then. But we'll move on to our next speaker. We've got it's because of competition and regulation, which makes it so the NHS has to. They're liable, so they need to make it safe. And it is the process in an organization for somebody to get kit is not as complicated as that, but the process that the companies that want to get on the frameworks need to do is much harder and higher. The kind of thresholds are higher. But next up, we've got an example of how an integrated care system can work. So we've got Georgina Dean, who is the Executive Director of Finance at North East Ambulance Service NHS Foundation Trust, who's going to talk to you about their journey to integrated care systems. Georgina, are you?
Then every something chats with.
Hi everyone. Hope you can hear me. I'm actually at a conference today, so I'm trying to find a quiet space so that I can come and talk to you. I have got some slides, which I will share. So it's interesting actually when I was preparing for today. So I think I've done this talk, I don't know, 4 or 5 times in total. I've actually moved systems. Regions and jobs, so I'm now in a different system, but actually the landscape is changing quite a lot around systems and what does it mean and what are the expectations. So what I'm going to do is I'm going to talk to you a little bit about why we all were taken on this journey to ICS. Where has it got to? Has it delivered what was expected? But actually what's next? Because like I say, I think there are some differences now to what we probably anticipated initially. So if I just share the slides.
So they've not called out anything to us as being live in a local NHS or UK environment. What appears to be their flagship is Australia deployment. So we can re-ask the question to see if that has changed since fit. I think process you never know. But yeah, it's also I can't understand that they're flash to be.
Okay, so I now work in North East Cumbria. So it's a very large, geographically spread system, and it has a real mixture of really, really rural areas as well as quite urban centres. Prior to this, I was actually working in the Black Country system, which is down in the Midlands. Very different again, much more urban. But actually this idea of working as a system is something that has been around for about 3 or 4 years now. And so I thought it'd be helpful. Just this is what, if you go back and you look at what was the point? What do we mean by an integrated care system? It was about actually bringing people together. So in the NHS, in particular, over the years, we've obviously had different approaches, but actually, in some ways, it was set up almost competition. Trust competing against each other. That commissioner-provider relationship, again, being quite transactional, sometimes adversarial, and actually doing that, does that really deliver the best for our populations? So the aim behind the integrated care systems was about bringing people together, bringing organisations together, and not just within the NHS, but local authorities in particular, to say, how do we really improve things for the people in our area? So you can see the core sort of purposes of an ICS are set out here. So it really is looking at that population health. What does our particular population need? What are the health outcomes we're looking at now? Where are the inequalities and how do we work together to improve them? But also looking at us in the NHS, but like I say, across the wider public sector, as actually we're quite large organisations. You might have heard the phrase anchor institutions. So we're actually big employers, we buy lots of products. Actually, we can have quite a positive impact on our local businesses and the local economy by working together, and things like buying locally, employing local people, etc. So it was about recognising all of those different elements. So that was why we sort of told, this is how we want you to work. and it makes sense. I don't think anybody could disagree that actually working together to tackle these areas is the right thing to do. Now, why? So why is it important? So what I've done here is I've just listed just a few facts about my current system. So you can see the issues. There's issues around poverty. We've got issues around suicide, drugs, people have ill health, heart disease, all of these things. And we know that actually the NHS on its own cannot solve these problems. One organisation on its own cannot solve all of this. It's going to take us working together, getting rid of those organisational boundaries, to look at the resources we've got in totality to say, how do we best solve some of these problems? Because actually we know poverty has a massive impact, for example, on someone's health and their life outcomes. And if you look at life expectancy from one part of our system to another, there can be a difference of 10 years just even in one area. So like I say, it seems quite obvious as to why we should be working together. And it's about working together, having a strategy to come together that we all work towards, and actually trying to break down some of those barriers, those organisational boundaries. So it isn't about it's me versus you. It's actually, how do we look at it together for the benefit of our population? So, like I say, when you start looking at the challenges we're all meeting, and we've all got slightly different things in our systems, but makes sense that we need to come together and get the most from the resources that we've got. So we have an integrated care system. Within that, you have something called an integrated care partnership. So you've got the integrated care board, which used to be the CCG, so the commissioning part of it. And then you've got all of your other different elements to it. So this is the one for my system. So you've got hospitals, ambulance, primary care, mental health. You've got councils. You've got the voluntary sector in there, community service providers, Health Watch. So the idea is you've got a much broader range of people. Now, the Integrated Care Partnership, they're not there to run services operationally day to day, but they are there to look and set that strategy and say, what do we need to do? What should our priorities be across our system? Where are we all going to agree to work together to improve things and have the greatest impact? So again, different way of working, but actually it sort of makes sense because often we're working on the same sort of things. So children and young people often comes up as a priority for a lot of systems. And actually, clearly, you start thinking about education as well as health services, if you're really going to have an impact. So that's the idea. You have your integrated care board, which is an organisation, which is your commissioner in effect. You've got your trusts, primary care, councils, and all of those together form the integrated care partnership. So that's the theory. So like I say, I think it's up to 3 years now of having this in place. And obviously it came into place sort of just coming to the end of those COVID times where we'd all worked very differently anyway, and actually probably seen some of those benefits. We'd sort of push some of those organisational barriers out of the way, hadn't we, during COVID to do the right thing? So I suppose you could say it was a bit of an evolution from where we were. So in reality, and like I say, I've moved systems in the last 6 months, and I think there's differences, but there are mainly quite similarities. But what we're actually seeing is, so there'll be the ICP, the partnership has the strategy where they set out those priorities, but actually day to day, it's the ICB that are really making the decisions and trying to drive through those priorities. We're seeing that providers are coming together more and working through collaboratives, so that there's lots of different forms of how that works. So a provider collaborative, there might be a mental health collaborative, all different ways of doing that. But that again is that's coming together, and they've become actually quite powerful, and actually working together can make some big changes. So that's been really positive. We hear a lot about place. So if you imagine you've got your system and then that's split into places, and actually that's where I think we see a lot of the integration actually happening on the ground. So in most systems, you're seeing that there are place partnerships where the different partners in that area come together and say, right, what are we going to do for our population? What is it that our bit needs? Because again, it might be slightly different to the wider system. So that's been developing. Again, it's really variable. In some places, they might even have delegated budgets at a place level. In other areas, it's not quite there yet, but there are definitely some examples of, so if I think about my system now, what we're doing in Teesside and how we're working together as a system there, it's a bit different to what we're doing in Sunderland, it's different to what we're doing in Northumberland, but the different places are trying to adapt services and develop them to suit that population. But what we're now seeing is almost the next layer, which is the neighbourhood level. So you're talking your sort of 50,000 sort of population, and how that, what do we need to do? So you've probably seen in the plan around neighbourhood teams where you're bringing people together. Actually, there's a lot of money available for physical buildings, so that again, different providers, different people can work in that same building and really support the community in that way. So I think there's definitely been progress. We've definitely seen better working together, better alliances. So that has made a difference. Has it fully delivered everything? I think you'd say it was probably variable across the country. Is often the case. A lot of these things are based on relationships and about people working together, shared values, shared vision. That's what really makes things happen quite often, not the structures like this around it. So I thought it was worth putting this one in because the finances and the way that they have been managed across systems has driven some of the changes, but it's all changing from the 1st of April where we move into the new financial year. So, but how it has been working since we had the integrated care system is actually your own organisational plan and your duty to break even, so live within your budgets. It wasn't just at an individual level. We all had to work together to support each other. And what that actually meant in practical terms was that if the one organisation in your system was struggling, that others elsewhere in the system might be asked to do more to support that. Because overall, we needed to balance. NHS England looked at us as a whole rather than individually in terms of managing things. So very different conversations to what we'd had before. And actually that very traditional transactional commissioner relationship really went out the window because it was all about how do we get everybody back to balance. There are positives and negatives to that. I mean, the positive obviously is that we all had to come together to say what's the best way that we spend this money for the benefit of the population. That's the theory. In reality, what happened was we had historic contracts, which through COVID were all made block contracts. It was all rolled forward. And now it's quite difficult in some places to see the link between the money that an organisation is being paid and the activity being delivered. So there's a process going on at the moment called deconstructing the blocks, which is about trying to get back to that linking activity and finance and performance and more, but quite a lot to undo, and quite difficult to, I suppose, disentangle all of that. So in a way, if you manage the money in that way, like I say, it can force people to work differently, to think differently. And actually the same approach was taken for our capital investments. So the system is given a capital pot of money and then that is split. So then you get into the discussions about how much do we need to spend on new ambulances versus an MRI scanner versus refurbishing a ward versus some medical equipment, whatever it might be. So it's been an interesting few years working through that. But I think one of the things it did was that we all had a much better understanding of each other's risks and challenges. We understand each other's plans a bit more, and it allows you to say, do we really want to spend money on building something over there, because actually I've got this over here. And just really simply, our local mental health trust was going to dispose of some surplus land. Actually, it's next to one of my ambulance stations, so we've had a great conversation, and we're going to buy that land because that's useful for us. So actually, there's some really good things about how we've come together to manage that. But like I say, it's all changing at the end of the month, and come 26, 27, it will all work slightly differently. So we're going back to this organisational sovereignty, this organisational responsibility. And what's happened is the ICB used to almost hold the ring for the system around money and planning and everything. And then they would, in effect, interact with NHS England. So the ICBs would performance manage us. What's happening now is that's changing, and the performance management goes back to NHS England, directly managing the providers, and the ICB role goes back to being commissioning. But actually, it's supposed to be about strategic commissioning, and focusing on that. If you go back to the purpose that I set out at the very beginning about how do we improve the health of our population? How do we deal with the health inequalities? So the ICBs should be smaller organisations. So you'll probably be aware of the requirements for ICBs to reduce by about 50%. And that's because their roles are supposed to be more, like I say, much more focused on the strategic side of it and setting the direction, and actually going forward, the way that services will be commissioned will be different. It should be much more outcome focused rather than transactional. So there's a lot of flux at the moment. I think ICBs are obviously going through a lot of change in terms of staff leaving and really understanding what their role is in the future. So that's quite difficult. We've had the old ways of contracts and commissioning seems to be coming back a bit, which there are definitely benefits to that, but actually we don't want to lose some of the really good things that we've got from system working. As I've said, we're looking at the deconstructing the contracts so that it better reflects you're paid what it should be paid, and its value for money, and the capital element is back to being set at an organisational level. Now, like I say, we're all sort of readjusting and trying to work out what does that actually mean, and how should we work together, because I think logically, for example, for me in the ambulance service, obviously working with the acutes is really important in terms of how many people are we conveying to EDs, what's that handover like when we get there. If we work together on that, it's going to be better for the patient. So we can't lose those relationships, I suppose, is my thoughts. But the system and the structure around us is changing and almost taking us back to that individual organisational focus. The integrated care partnership, it's not really clear how that might work going forward. But again, working with the local authorities is really important, clearly, if we're going to really drive that change. So we're in a bit of flux at the moment, I think it's fair to say. And I think because of what's happening at the ICBs with all the changes, certainly the providers and the provider collaboratives that I mentioned before, in effect, they are picking up some of this. They are taking on some of those commissioning roles. So in my previous organisation, we'd already taken on responsibility for commissioning of services, and that's the sort of conversations that we're having now. So a lot of change going on at the moment, and it's not quite settled, and it's not, people are still sort of finding their way through it. So what does it mean in the future? Like I say, the ICB is still there. They're still they've got this overarching role about the population, so they will still be trying to bring everybody together for the benefit of the population. But in some respects now that has to be through that contractual mechanism with them being the commissioner. which is different. It doesn't mean it can't work, but obviously it's different. We've then got IHOs, integrated health organisations, which you may have heard mentioned. And the idea being that that's an organisation that takes responsibility for the health of an area, and there's lots of different thinking about how that could work financially, but actually they then always commission on behalf of the ICB and be responsible for delivering the best for that population. They'd have the whole budget and they would decide the best way to spend that. And then the neighbourhood health, as I said, that's really developing at quite a pace. There's a lot of money being put into it because that's really seen as the future delivery model, I suppose, for the NHS and the benefits for the patient. It's the left shift that we all hear about moving more to prevention, care closer to home, and less people going to hospitals. So it's all, because there's a lot of change going on at the moment. We're all just gone through the planning process and putting our plans, 3-year plans. But it is all a bit different and in quite a lot of flux. So it's been an interesting few years. And I suppose my thought is that I just hope we don't lose the benefits that we've had from the closer system working. And I don't think we will, because it is down to those relationships ultimately. So I'll stop sharing there, and I'm really happy to take any questions. No questions.
Anyone's got any questions that come through after you've gone, Georgina, are you happy for them to drop you an email?
Yeah, that's absolutely fine. I'm just thinking, are you excited future of the I'm always a positive optimist, so I am positive about it. I think we all have to keep that mindset of system first because it's the best for the patient. And we have to, so in my role with finance, we've got to try and make it work. We've got to make the money work around it. So I always think if you put patient in the centre of it, everything else should follow, shouldn't it? So we've got to hold on to that, haven't we? That's our job as leaders, I think, in the NHS to try and make that happen. And sometimes that may mean your organisation loses out, but actually it's looking for the wider benefit. It's just the NHS, isn't it? It's constant change, and you've got to just focus on what you can control, I think. So yeah.
Let's wait a little, so see if there's any more questions that come through. Get a little bit of time back, which will be nice.
Funny position.
It's normally much more. Yeah, you're right. You focus on the circle of influence, and I always go back to, like, if you're delivering great care and your staff are happy, your patients are getting good outcomes. That's what we're here for, isn't it? So that's what we all have to focus on, really. And you sometimes can't worry about the bigger everything, all the changes going on around you, can you? Because patients still come through the door and need support every day.
Yes, and any other questions? We've finished a little bit early, so get a little bit of time back. As I said, if anyone does have any questions after you've gone, Georgina, I'll forward them on to you if that's okay. Thank you so much, though. That was really interesting. Thanks for giving us your time. We will be going on a little lunch break now until 12:50. So we'll be joined by Steve Lee, Head of Finance at University Hospitals of Leicester, so for an introduction to NHS costing clicks for acute trusts. So we'll meet you all back here at 12:50. Hi everybody, welcome back. I hope you all managed to get something to eat, have a bit of a break. So we're going to be joined now by Steve Lee, who's Head of Finance at University Hospitals Leicester, with introduction to NHS costing and clicks for acute trusts. Steve, are you on the call?
I am indeed.
Great. Over to you then, Steve.
Lovely, thanks very much. I'll share my screen. Hi everyone, good to see so many of you on here. As Ellie said, my name's Steve. I'm one of the heads of finance at Leicester with the responsibility for our PLIC system. So I'm going to talk to you today a little bit about what costing is and why that's different to kind of traditional financial management, why it's important, how we do it, and then how you can use that information to hopefully support your services to improve patient care and the efficiency and productivity of your services. I think we've got about half an hour, so it's a bit of a whistle-stop tour. But I would encourage you to talk to people within your organisations about this if you've not already done so, and you think it's something that you think will add value. So the boring technical bits, what is costing? In essence, it's the quantification in money terms, what the value of the resources are that you consume in producing a certain unit of output. So within an NHS healthcare setting, that's in essence how much it costs to deliver our services and to treat the patients that we see. Within the NHS, PLICs or patient level information and costing systems have been implemented across the acute sector as a standardised approach to costing. And we'll go into a little bit more detail about what PLICs is. I'm not sure whether you've had your budgets and financial management session earlier on this morning or whether that comes a bit later on. But there's a few key differences to what we do within costing and PLICs and how that differs to traditional financial management reporting. So it's really important to note that we don't look at budgets. So we just look at what you actually spend and the income that you generate. And it looks at a fully absorbed picture of the costs that you incur to deliver your services. So that takes in things like your support services, corporate areas, and bits and bobs like that. So why do we do it? I think we all know about the scale of the financial challenge facing the NHS. There's lots and lots of stuff to read on that. But the one key takeaway that I have from that is that if you can't measure your cost, it's really difficult to improve it. So using costing and understanding what drives those costs is the only way that we can really address some of those financial challenges. So specifically PLICs, and you might hear the terminology service line reporting as we go through this presentation and discussions with your costing colleagues back at your organisations. So what is it? So the patient level information and costing system is a system that enables you to calculate costs by tracing the resources that are consumed by your patients. So we do that by taking lots of different activity information about what happens to those patients and link that up with the information that we see in the financial ledgers. When we do it at that level, it's a really granular, detailed analysis of costs that we can look at in a number of different ways, and we can compare that to our income that we receive for those specific activities. And if we aggregate that data up to produce an I&E position for a service or a group of services, that can sometimes be referred to as service line reporting. So some of the benefits of that, and again, we'll probably cover this a little bit later on, is that analysis doesn't just look at what money you're spending compared to the plan that you've been set. It combines both that cost information and activity. It will allow you to look at what services are profitable or not, or what procedures might be. Can help you with coding and counting of your activity. You can do analysis on pathways, and you can start to look at things like clinical variation. When you pull together all of that really granular detail. How do we do it? It's much more complicated than this, but this gives you a good flavour of what we do within the system. So the starting point is that we take some key information sources about the patients that you see within your hospitals. So when we talk about consultant episodes, that will be your admitted patient care, your elective inpatients, your non-elective inpatients, and your day case activity. So we'll look at all those patients that come through the door in those settings, in your outpatient setting, in A&E, and then any other types of attendances you might have through your hospital. Here in Leicester, we've got quite a big renal dialysis service, and there are a few others as well. So we take those core attendance, that core attendance data, and we take your core ledger information. So what money do you spend, in what areas, and on what things? What we then do is link all of that information back to a whole host of data sources that tell us about what might drive those costs. So we'll look at information about how long your patients stay on wards, what wards they stay on, how long they might be in theatre for, and how many staff are within that theatre session that they're there for. What diagnostics those patients might have whilst they're in hospital, what drugs they're issued, what physiotherapy and occupational therapy contacts they might have. I've also got on there high cost devices as well. There are lots and lots of other things that tell us about what have happened to patients that we use. I think at our trust we've got about 40 different information sources that tell us about what happens to patients, but they're some of the big ones. So we link all of that information back to each attendance. So what's ward stay, what pathology related to what attendance, and then we weight the costs that are incurred by each of those supporting services and each of those areas across the trust, to show the kind of complexity of those and how that then relates to the costs in the ledger. So there's a huge matrix that's pulled together in a SQL database. The way that those things are matched and weighted to derive a cost are all done in line with NHS national costing guidance. So if you compare costs across organisation later down the line, you should find that they're reasonably consistent because everybody sticks to a set way of costing. The great thing about that is the end of it, after it comes out of the sausage machine, you can end up with an itemised bill for every patient that comes through your door. And you can see that compared to the income that we generate as a trust for that individual attendance or episode. That's all underpinned by activity data, and as mentioned before, we can aggregate it to show the financial position or the income and expenditure position of various levels across the organisation. So that might be a patient level, it might be a specialty level. We could also do it at a healthcare resource group level, so you're comparing like for like activity, or we could do it at an individual consultant level. So lots of different ways we can cut that data and potentially use it once we're familiar with it and we've got assurances over the quality of that data. And the image on the right hand side of that slide is just a representation of some of the different elements that we'll take into account when costing that patient journey. So all the kind of direct contacts that a patient might have, and then at the bottom the different things that would then span the care that's provided to that patient and the costs that are incurred by the hospital in order for those things to happen. So that could be your trust overheads, it could be your clinical management group, management teams and admin support, it could be your estates and facilities areas. Ultimately, most organisations then publish this data into a set of dashboards, and these dashboards will look different dependent on your software supplier and whether you have gone on to develop your own metrics and outputs. But this is just a flavour of what kind of thing you might be able to expect to see. So here at Leicester, there's two kind of extreme examples on here. So the first one with the stacked bar chart is an episode level representation of costs. So we can see the costs that go into treating a patient whilst they were in our hospitals for each of the days that they were under our care, and the different coloured bars are the different types of cost that happened within that stay. So you can see on this example there's a couple of days at the start of the episode where there wasn't an awful lot that happened to that patient. They then go on, have a procedure, and there's subsequent care that goes on through. So you can not only look at the total cost of treating that patient, but you can see when interventions happen, when there may be bottlenecks in terms of moving patients throughout their pathway, and you can potentially highlight a number of different things. We also do some summarised information in the tabular illustration there. There's the overall summary for a particular service that tells you it costs them around £14 million to deliver their service, and the income they generate through tariff is only nearly 10 million. So they're running a significant loss of around about 4 million. What we can then do is kind of illustrate the healthcare resource groups that contribute to that. So we've listed the kind of top 5 loss makers and the top 5 profit makers in there, and you can drill down through multiple different views of this data. So it's just to give you a bit of a feel. I think once you've spoken to your costing teams, if you're interested in this kind of thing, understanding what it costs to truly deliver your services, and when you take into account all of the costs of the organisation, the really well, I say fun bit, it's fun for me, is how you can then use that to analyse your services, to improve them, to share best practice and that kind of thing. So first and foremost, that data and the transparency that it provides can give a really good understanding of your economic drivers. So it can tell you what is causing you to spend the amount of money that you are spending. So is it because of the volume of your patients? Is it because those patients are staying in hospital beds longer than they might do at peer organisations or across peer clinicians, that kind of thing. It also allows us to benchmark. So I mentioned that we produce it to national standards. That means that we can compare the costs of our services and treatments both internally, as an example, between clinicians, or against external peer organisations who provide the same kind of activities. The granularity of that data allows us to see the way that each clinician treats those patients and where that variation might occur. So if you've got one clinician that's more expensive than another, is it because they operate on a Friday and don't discharge patients over the weekend until a Monday, when another clinician may have his list on a Monday and be able to discharge on a Tuesday or a Wednesday, so they'll have a shorter length stay? Or is it because of the volumes of diagnostic tests that they undertake or the amount of time that they take in theatre? And so it's a really, really good benchmarking tool that puts a kind of number to scale the opportunities that you might see from variation. It can also support and provide context to some other information across the trust, and I've kind of alluded to that just now. So there are lots of information sources across the organisation that tells you about your services. Sometimes they will show variation, but you don't know the true impact of that on your financial position. So it can really help to bring a lot of those different metrics and measures into one common currency. Here in Leicester, we've used the data to help inform tariffs. So there's 2 ways that can happen. The cost collection goes off nationally to NHS, and that should be then used to determine what tariffs are paid, although it's been a little while since they refreshed that data. But we can also use that data to negotiate local prices with our commissioners as well. So if you're able to see that you've got a really niche service and tariffs don't currently reflect the kind of complexities that you have within that, it can provide evidence to commissioners to let them know why you cost more and kind of negotiate those prices that are delivered. We can also support business case developments. So we can demonstrate the benefits of some of the changes and developments that we're looking at making, often we're expected to show those changes and benefits of a business case. Costing data can really helpfully quantify some of those things in financial terms. And we have lots of people coming and talking to us about changes that they want to make to a service. They have research kind of backed evidence to say what benefits that will have to the patient or to the capacity within the department, but they won't necessarily know how much money that might release or free up to be used in other ways. So we can help them to illustrate that using that linked activity and cost information. And it's also a really good measure to allow you to track your performance over time. So costing data, because you know about the complexity of the work that you do, the volumes of the work that you do, and the cost of providing those services, we can use that data to create measures to allow us to kind of monitor your productivity or efficiency over a point in time. And there are lots and lots of ways that this can help organisations. There's a few things that I've highlighted here that you can maybe take back to your organisations and talk about. One of those is some work that we've been doing in our A&E department, mapping patient pathway costs, looking at frequent flyers to A&E, and just looking at how much they cost our health economy. That's helped us to identify specific cohorts of patients who are those frequent flyers who are using the most resources. And we've developed a pilot to intervene with those patients before they come into A&E. So that specific one was around a homeless cohort, where they've set up a multidisciplinary team between kind of the nursing, the hospital, between health and social care colleagues, housing colleagues, things like that, to try and improve outcomes for those patients and minimise the amount they're coming in. There's some really good evidence to show that pilot has been really successful. One of the other things we've been doing is looking at the links between people who don't turn up to their outpatient attendances and then presentations in the emergency pathways. There's obviously a cost of them not attending their outpatient department attendance, because we put resource on to care for those patients, and we're seeing links in those people that don't attend, and then them presenting more frequently than others who do attend in A&E and subsequently as non-elective inpatients. And we're seeing that there's particularly strong links for people from areas of higher deprivation. So again, we're trying to evidence the kind of financial impact of that to see whether we can do more to get them to attend those outpatient department attendances. Trying to help with our prevention agenda as well at the organisation and across the patch, looking at costing the benefits of preventative care. So we're doing some work with alcohol and tobacco dependency services, with diabetes services as well, about the work that they're doing to reduce the number of attendances again. In a world where funds are really, really limited, they need to evidence that they're making an impact on the overall well-being of our population, and helping to reduce the future costs of the organisation. So by linking their attendance information and tracking certain cohorts of patients, we're able to put again a financial figure to the great work that they're doing. We're also using the data to try and assess the performance of some of our big capital developments to prove that they're kind of washing their own face, things like the East Midlands Planned Care Centre. So we're able to disaggregate our data at a point where we can look at that by site. So we can look at work that's done within that planned care centre compared to other areas within the hospital. And we're able to compare that specifically to other national data as well, to see that this is proving to be as productive and efficient as we wanted it to be. which incidentally it's not, but that highlights the need for further work within that sense to make the most of those resources. So there's lots going on within our organisation, and there's lots of ways that you can use that data within your organisations as well. I think I've got about 10 minutes left, so we'll talk a little bit about engagement really quickly and then open up for questions if we've got time. So this is kind of a bit of a plea to all of the people on this call, regardless as to whether you're a clinician, an ops manager, an allied health professional, or anybody else within the organisation. And it sounds obvious, but as a costing team and finance staff, we're by no means experts in caring for our patients. And most of you guys on the call won't be experts in NHS finance, but if we can work together to improve the quality of the data that we produce, hopefully the outputs can then help to improve the quality of care given and the financial sustainability of our organisations. People on the shop floor hold the key to understanding how we consume our resources, and you'll also have the ability to kind of influence changes relating to that. So it's really, really important that we work closely with you. You'll also know what data is recorded on the shop floor, and you can share that information and support us in ensuring that the costing data that we produce is as accurate as possible and reflective of how you undertake your work. You usually have a really good feel as well where processes could be improved, where there might be variation, where there might be bottlenecks, and where those opportunities lie. Hopefully, as a costing team within your finance department, we can help you to evidence or disprove some of those hypotheses and beliefs, and we can support the case for change on those things. Alongside that, we can hopefully help to identify new areas of opportunity that you might not be aware of, and through some of that internal analysis or benchmarking. And we pull together a lot of data and information that's not usually available all in one place. So we can hopefully give you a much rounded picture of your services. Really quickly, if you want to know more, there are lots of different resources out there. So there's information on the HFMA website, which is a healthcare financial management organisation. You can talk to finance and costing colleagues across your organisation. There are lots of finance and clinical educators out there, so FACE network members as part of One NHS Finance who'll be able to talk to you about this kind of thing or point you in the right direction. And I'd really encourage you to talk to your boards, whether that's a local divisional board, clinical management group board, or your trust board about PLICs in your organisation, how it can help you, and how there should be a lot of focus on this kind of data. So that, I think, is my slide. So I will open up. I think we've got a few minutes, 7 or 8 minutes for questions. I can see one that's just come through in the chat actually. So how many people are collecting this data in each trust? That's a great question. Thanks, Christine. It varies from trust to trust. So I'll use Leicester as an example, but not everybody might follow the same kind of resourcing and structure. So within Leicester, we're about a 1.6 billion turnover organisation, maybe 1.7 billion. We've got at the minute 4 people and 1 vacancy. They're not all full time, but near enough. And there is some benchmarking out there to look at that. I think there's been a few studies and things. I think there's something along some kind of guidelines along the line of 1 whole-time equivalent or something per £100 million, but I don't think any organisation's anywhere near that. I certainly talk to a lot of peers. There are some big acute teaching hospitals who've got similar sized teams to what we have here in Leicester, but there are some smaller organisations who only have one person dedicated to PLIX. And it's not always a kind of straight line in terms of the amount of work they'll be expected to do. So they'll still be expected to produce all the same data we will here in Leicester. They might have the same number of services. Those services might be smaller. So it's a real stretch for some of those people who have got smaller teams. And that's why I think it's really important to raise the profile of these things with your boards, to ensure that it is resourced appropriately, because it can add massive value if you're able to do it properly. There's a question on the frequent flyers in ED in terms of what was being piloted to reduce the attendances and how we're measuring the money saved. One of my colleagues looks at it, so I can't give masses of in-depth information, but it was mainly a multidisciplinary intervention team that were looking at some of those existing frequent flyers, having one-to-one regular meetings and conversations with them about the reasons that they were presenting, whether it was to do with the fact that they were homeless, whether there were other issues that they were dealing with, and providing them with a tailored package of care. The way that I think we were measuring that was then looking at subsequent attendances after those interventions to see whether those people were then attending as frequently as they were previously. And kind of coming up with a financial equation to say, if on average the attendances were costing us £300 each time they come in, and now they're coming in half as much, we just multiply those things up and work that through. I can probably dig out some slides that have been put together by that pilot group, but it was along those lines. And if you're interested, more than happy for you to email me directly, and I can point you in the direction of the people that are undertaking those pilots and are seeing that work move forwards. Another great question, do we actually map every single patient journey? We try to. So it all depends on how well the data is recorded across the organisation. So we know there are certain elements of a patient journey that aren't recorded, and there is no information for, which we obviously can't cost. But for every piece of activity that is recorded in terms of an attendance, we'll cost that. And for every piece of information we receive about what happens to that patient within their journey, we will attribute a cost to that. So I can't guarantee that it's 100% kind of accurate and fully reflective of every element, but where we're aware of it, we will trace that through the system and kind of pull that together. I think it'd be good for you to, who'd asked, Christine, to maybe try and touch base with whoever your costing person is within your organisation, to talk about what data they do collect, what are their limitations, because that may be different across different organisations based on the quality of data that you receive. I'm sure there's lots of people who've got far better data than what we have in Leicester, and I know there's some people that struggle with some of it as well. And one last quick one, do we use an integrated system or any specific system to capture data and to do costing? So the capturing of most of the source data for us comes from a wide range of systems, but we're looking at gradually moving over to Nerve Centre within our organisation, which will be our electronic patient record. That's being built kind of incrementally for us, but we pull in from lots of different data sources that go into a data warehouse. And then we also pull in lots of manual data as well. That will vary dependent on the trust that you're in. There are then a few recognised costing systems that we use to process the data and do the costing. Again, I think it is probably important for you to talk to your organisation and your costing colleagues at your organisations about what those systems do, what the benefits are, and whether that's suited to the way that your organisation works. But there are a number of those systems that are all kind of approved and are available on frameworks. So they should all do really similar jobs. And as I say, we should follow national guidance as to how we do that. I hope that's been useful. I'm always happy for people to contact me directly if they've got questions. If you don't know who your costing people are, somebody within your organisation certainly should do. And there are lots of FACE representatives on the NHS Finance website, I think. So they're probably a good route in. But yeah, feel free if there's any other general questions to get in touch with me directly.
Thanks so much, Steve. Have a good rest of your day.
No problem. Thank you very much. See you soon.
See you. So we are now joined by Claire Jacqueline, who is going to be doing the same thing, but for mental health trusts. So Claire is Senior Costing Accountant at Humber Teaching NHS Foundation Trust. So Claire, I believe I saw your name on the call. Are you here?
I am here.
Oh, you are. You're already sharing. Amazing.
I've just shared my screen, so hopefully you'll be able to see my slides.
Yep.
And I do the presentation slightly different to Steve in that I go through quite a lot of slides, but I will skip through bits. But when I am presenting, I actually can't see the questions, so I'll come back to those at the end, if that's okay.
Great. Thanks, Claire.
Right. As you can see, my name's Claire Jacqueline. I'm the Senior Costing Accountant at Humber. We're a mental health trust. And today we are going to be talking about a little bit about Humber. What is costing? Why we costing in a mental health provider and how that's different to our acute peers. Patient level costing and understanding the patient journey and how cost information can improve patient care. So the same topics that Stephen's just discussed, but from a mental health sort of perspective. A little bit about Humber. Compared to Stephen's Trust, we're really small. We're about 280 million, but we have around 180 different service lines, and there is 1.8 whole-time equivalents completing all of the costing for all of the services that we have. So we do cover quite a lot of information. We've got about 3,600 staff, and we cover quite a widespread geographical area where we deliver a lot of our care out in the community, not in a hospital, in patients' own homes or different sort of settings. So what is costing? Costing is the proposed or estimated cost of producing or undertaking something. And costing sort of quantifies the financial value of the resources that we use and that are consumed when we carry out activities in delivering care to people. So the resources in our terms will be like nurses or occupational therapists, speech and language therapists, etc. And we look at the activities. So every contact that we deliver with those patients, we record in our electronic patient record. Every day that they're spent in the beds, we look at all the sort of supporting activity that we have to do to deliver care to those patients too. So we do include in our costing system information about how much time we've spent with liaison with other bodies, because we'll often have to talk to the police or schools, or even our other clinical staff. So we're in our multidisciplinary teams. We spend quite a lot of time as well, which isn't actually on this list of activity examples, doing travelling to patients as well. So we need in our system in mental health to look at how much time we do that, and try and hopefully reduce the time on the road so we have more time to deliver care with the patients. So why do we cost? Obviously, NHS is a public funded body and we need to explain how we are spending the money. Each month we submit activity information to NHSE through the MHSDS data submission. We also submit data through things like staff data collections, and annually we submit our costs nationally via a national cost collection which is an annual mandated return. It's part of our provider license that we have to submit a schedule of costs of how much it takes us to deliver care across patients and resource groups, to allow us to have direct comparisons between my trust and other trusts that are delivering the different care to each of the patients. To do this, data nationally is used to inform lots of different things. It goes into things like patient level information costing and dashboards for people to use as comparison tools. It goes into model health system. It goes into the getting it right first time program, NHS payment schedule of prices and schemes. So it is used in a lot of places, but more recently it's been part of the national oversight frameworks and segmentation and league tables. So it's all used in evaluating how well your trust is performing, highlighting areas of inefficiencies. So we do spend a lot of time looking at the sort of the relative difference in costs from our national cost collection return. And more recently, they've been looking for mental health. A lot of our payment is already at the moment through block contracts. So we are in the process of trying to break down our block contracts into more representative sort of income, activity and performance contracts. So we're trying to understand what is being paid for and how we're then delivering it as well. So it's a key source of information about the NHS and the services that we deliver. So locally, why do we cost? Pretty much so we can inform and make the best evidence-based decisions that we can about the places that we work. So where we offer services. For some patients, the mental health illness may not be productive for them to go into a big hospital environment. So care in smaller locations or places where the patient feels secure is key to part of their treatment. The first one that I missed initially was around people. Obviously, what skills and training do we offer our staff and what do they require? And also about what service do we deliver, what services do we deliver, and how we cost in delivering those. Is one method of delivering that service more effective and have a better outcome than another methodology? So costing allows us to start asking questions about what we are delivering and how comparable it is to others. It doesn't say whether something's good, bad or indifferent, but it allows you to see issues and questions. It may also just sort of demonstrate areas of good practice that we can highlight to the rest of the organisation. So why do we cost? I'm not going to ask you to all answer this question, but if Team A spends £10,000 less than budget and Team B spends £10,000 more than budget, which team is doing better than the other? So from a traditional financial management accountant's role, where we tend to look at whether we're spending more or less than budget, Team A that is spending less would probably look better than Team B. But from a costing perspective, we just know that there's not enough information there. So the same example again, but now we've got the activities involved. So Team A is still spending less than budget, but they're now doing 500 activities, contacts, patient contacts, and Team B is spending more and doing 700 contacts. So Team B's cost per contact is actually cheaper than Team A's. So which team is doing better? And from a costing perspective, although I have more information now, I still don't have enough information. Team B now looks that they're more efficient, but there's no information here at the moment around outcomes for the patient. And so we don't know whether we've actually made a difference doing all of these activities in a mental health setting. Because it's not quite as straightforward as within an acute. If you have a hip replacement, you would be in and out in a certain number of days. With mental health, some of these illnesses can last you a lifetime. So why do we cost? The notional value of healthcare is largely based on the work from Professor Robert Kaplan and Michael Porter of Harvard Business School in the US, and they define that the value, define value as healthcare outcomes achieved that matter to patients relative to the cost of achieving those outcomes. So are we making a difference? If we don't cost, we can't understand the bottom part of this in this equation. And so we need to start pulling through cost and activity information to bring that through. Also, why do we cost? There's quite a lot at the moment around health inequalities, and do we understand if we're providing care fairly and addressing health inequalities? If you don't have the information about your patients, it's very difficult to understand whether you are delivering care fairly to all patients across all walks of life and all environments, and with similar sort of mental health needs. So this is some information that was an article published by the King's Fund back in 2024, and deprivation and the scores here. So 1 is the most deprived areas, 10 is the least deprived areas, but it tells a very stark picture. And so if there's a difference of 18 years in life expectancy between patients, or the number of patients that sort of have a decent quality of life, they've got good health, or their health is poor, sort of compared to the retirement age, it's very key to understand the information that we have. This is a more local version of that data from my trust perspective. This is 2 geographic locations in my area. They are literally 5 miles apart, and the statistics tell a very stark picture about the health inequalities within those areas. So this is data that's not costing data. It's available out there with public health, but I can go through and compare how I deliver, or how our trust delivers care to those communities. So on this next slide, these are both community mental health teams that deliver care to those areas. The decile, the number of patients that you can see in Team A with the most deprived area is obviously higher than in Team B. When you add the cost information to that, it seems to follow the same profile. But if we're delivering care fairly, I would expect, when I look at an average cost per patient chart, that the cost per patient per decile would be at least flat in this sort of picture. Unfortunately, in my trust, in this particular area, we are spending a lot more on patients in deciles 3 and 4 than we are in patients deciles 1 and 2, which are the most needy. And that gives us a question to ask: what is stopping us delivering care to those patients in deciles 1 and 2? Are they not engaging with us? Why are they not engaging with us? Are we offering appointments at a time when they can't attend because they need to go to work? Maybe they're in financial poverty. It helps us to view how we deliver care and where we deliver care and when we deliver care, if we can use the costing information well. So you can cost anything with the right information, but the data does not have to be perfect. But the better the data is, the more reliable the outputs. We do rely on a lot of information from our electronic patient record and our staff recording that information. And obviously the setup and the reliability of the costing system, its data sources and its outputs all improve over time with engagement. So I'm going to echo Steve's plea earlier, is get involved with your costing teams, see what information that they have, review it. If there's something that looks odd, point it out. It may be that we've got something wrong in the way that we've allocated things or mapped things, but it may be that it's highlighting an issue in there. But by talking with each other, hopefully we can improve things. Difficulties in costing in a mental health provider is something that I did want to consider. The accurate recording of data is kind of vital to make the best decisions. If you've recorded the information correctly, you have a much more confidence in what you are doing. But in mental health, we've never had a national payment by results tariff. We've had little to no, or we have little to no clinical coders. So everything that's in the system is from all of our clinical staff recorded. And in mental health, we don't have the same grouping or categorisation that there is in the acutes, where there's a plethora of health resource groups. So you can compare apples and apples. In mental health, that's still developing. So there are new mental health and neurodevelopment resource groups being developed. This was launched back in March 2024. It's still being developed, and there's lots of data on NHS Futures around that if you want to sort of review that. But this is an example of the changes. So anything highlighted in a red box at the moment is a change to the currency from the previous years and how they've set up the currencies. So pretty much between what we submitted in our national cost collection in 2024-25 data and what we are about to submit for our 25-26 data is different. So it makes it a bit harder for us to make meaningful comparisons year on year, but we do the best that we can with the information that we have. And the final difficulty in costing mental health and measuring is costing outcomes. We're not great at saying whether we've made a difference to the patient because of as I say, there can be patients with us for a very, very long time. And naturally, some patients will decline depending on their type of mental illness. So there are PROMs, CROMs and PREMs. We're not great at collecting or using that information in mental health costing yet. So PROMs are like questions that we ask about the health and well-being. This could be things like recovery and quality of life, REQUAL, or goal-based outcomes, this sort of information. CROMs are used in the rehabilitation to evaluate and track patients' health status and recovery. This things like health of the nation outcome scales and different metrics like that, which comprises of scales to measure behaviour, impairment and symptoms and social functioning. And PREMs are the patient's own view of their experience while they're receiving care. So it might be things like the Friends and Family Test, but it's for costing, it's quite difficult at the moment to get access to some of that data in mental health and incorporating that into whether we're making a difference or demonstrating a difference in the improving patients' outcomes. So it's still something that we need to develop, but until they've pinned down the currencies and the groupings and then the PROMs and the CROMs and the PREMs, we're still very much behind where the acutes are in that sort of sense, but we're trying to get there. So PLIX does join together the healthcare activity information with the financial information. It provides us with the information about how we're using our staff and our drugs and our tests and all of that sort of information. And it helps us to provide target areas and focus in areas that need improvement or to showcase that those are doing well. And it's key that we allocate cost to patients in a meaningful way so that we're consistent and fair and comparable. So there are lots of rules around how we do costing. So for things like non-paid costs, methods may include looking at your estate and capital costs and allocating them based on the buildings and the room usages. This changed quite a lot for us in mental health with COVID. Quite a lot of our rooms now use booking apps. Sorry, I can hear somebody else in the background. Thank you. So a lot of our services book spaces into particular rooms and don't have set bases quite as much as they used to. So it pulls in quite a lot of information. We allocate HR and payroll costs using actual whole time equivalents. We have IT system costs, which we allocate using user licenses to the particular IT system. We break down insurance costs based on a particular CNST schedule broken down by cost centre and so on. But there is an approved costing guidance that tells us how to do each of these things. And you can go view that if you want to to get into the depths of costing. But for us in the mental health setting, pay is the biggest element of our cost. And I've seen a variety of ways that you can use or allocate pay. One, and the most simple way, is to take total pay cost and allocate it based on all of the activity that pay cost or that staff member has done. From my perspective, I can understand the use of this if, say, you are an acute trust and you've got an operating theatre and you've got one anaesthetist, one nurse, one surgeon or whatever within that. So it's a set basis and it's always that sort of makeup. For mental health, there's a big disadvantage for us because generally one staff member will go out to see a patient and they could be a band 5, they could be a band 7. There are big disparities between pay rates. And actually then if that staff member has only recorded one patient activity before going out, say going on sick, it would take their full pay costs, including their sick pay, and allocate it to that one patient disproportionately. So it overinflates the pay costs. Here at Humber, we use a 2-stage method. So we work out a pay cost per minute for every staff member based on the whole time equivalent work and adjust it to take off any non-clinically available time, so time that they'll spend on holiday or training, and there is an allowance for a sickness in there. It's a standard pay calculation. It's not a perfect pay calculation to work out a pay rate per minute. And we then allocate this pay rate to every minute the staff member has recorded to every activity they've done to the patients. So it allocates the pay costs to patients based on the time that they've spent doing work on, to and for them. This doesn't allocate a full pay cost for any staff member that we have, as staff don't actually record 100% of their time doing face-to-face work. There will be times when they've got to do meetings or different bits and pieces, which isn't time that they would be doing certain clinical work or some clinical work, particularly if they've got more managerial of a role and do less patient-facing work. Then any of the pay cost that's not allocated in the first stage is allocated based on the activities of the team. The benefits of doing this, it gives a fair reflection of the cost of pay to the patient when staff sickness or low recording occur, and it allows us to monitor and compare staff resource usage. So for staff A and staff B, I can look at how much their time they've spent of their clinically available time doing work against patients, and I can see the differences between them. If these two staff members are doing the same role, and you would expect them to be having the similar amount of patient-facing time, it's questions you can start to dig into as to why there is a difference. Actually, it might be that these two staff members, one has more of a managerial role, and then there's not an issue, but the services understand this a bit more. The main disadvantage of this is obviously it's also time and effort, because we have to collate the information and calculate the results. The more complex your costing system is, it can slow it down somewhat. But from that information, we can start looking at how productive and staff are, compare how they're performing. You might notice a little blip here where staff member R on the first row here has 110%, which is an impossibility really, but it's because our calculation is not a perfect calculation. And actually, if this staff member has worked and completed overtime in August, the activity would go into August, but the pay, because they would claim overtime, would not be paid until September, and so you'd have a drop off in September. And so there can be funnies, but you can then start comparing staff and what they're delivering, and start looking at to what's causing the barriers to being able to do this. Is it training? Is it the way that we're planning our care of patients and that sort of thing? So the data is at staff member and can be aggregated anyway, reviewed in a different variety, in a different way by roles or by banding or by teams or by divisions, and we can spend time reviewing that. And we use it to highlight splits in time between direct patient care and also indirect. So in the indirect supporting activity, that's how long does it spend doing the clinical administration, the travel, the MDTs, the liaison with other bodies. So this at the moment is a total one, but I could split it down into different levels if I wanted to. Ultimately, the aim of our trust is to increase the time that we have for direct patient care, because we want to make a difference. So we're spending time looking at what's stopping us do that. It's quite a big focus within the trust. Other information that comes out from our costing system is often productivity information. So this is some information around did not attends. And actually, if I've got a did not attend, patient did not attend, would I still spend an hour waiting and doing nothing else? So is this an issue within my system? Is the staff member not able to do anything else? What's causing these problems? So we can look at that. The bottom table here looks at travel time and duration. So staff member M recording 31% of their time travelling, but D at the bottom here is only spending 8.9% of their time travelling. Does M need to be planning their routes better? We have technology that can plan our appointments out in the community. Or is it just generally that patient M covers a wider geographical spread, and that's what we would expect from them? It just asks questions, gives us things to ask questions on. Productivity is a massive thing within our trust, and we established back in 2023 a group to look at productivity efficiency, making sure that the financial balance is there and the operational performance is there, because without any of these things, if it's not in financial balance, your productivity and your efficiency drops off, as with the operational performance, it drops off. Productivity, obviously, is how much output is produced in a given time, and efficiency is how well resources, time, effort, costs are used to produce that output. So what does it mean for us? Productivity means focusing on the quantity and the quality, increasing output of direct patient care. Efficiency focuses on the right person doing the right things effectively at the right time. So we may improve efficiency. This may result in a cash release or an improvement in productivity, or both. So we're spending quite a lot of time doing productivity work. So by improving productivity, our aims are that we'll have shorter waits. If we have shorter waits, we have a reduced risk in backlog in our patients. Patients actually have a better continuity of care, and the patient should theoretically have better patient outcomes. So this concept of the golden thread is the thing that we pull and fiddle with and try and improve to increase the time that we have available to delivering patient care. From a costing perspective, improving our patient journey, we started a lot of this work looking at a national cost collection analysis and the targets, looking at the services that we were when we compared to the national average cost, we compared to the ones, we looked at the ones that were overspending massively and tried to understand why that was happening. So because of the ones with the biggest financial overspends, we then spent time doing productivity deep dives on those, looked at things like staffing, resource usage, sickness, vacancy rates, what were we spending on agency, what waiting lists we had, DNAs, and capacity and demand and that sort of stuff. We then went on to doing staff training, because some of this analysis on the NCCI scores were wrong or too high, because some of our staff actually weren't recording some of the information in the EPR. So we moved through quite a lot of that, and done a lot of training and improving our guidance for our staffs to make sure information is put in the system in the first place for us to use. there's quite a lot of work that we've done on systems and developing systems to ensure that we can collect the data, making sure it's easier to collect in our EPR, consistent across all units, and the digital enablers I'll go on to on the next slide, but I realise I am running out of time, so I'm going to probably have to miss a few bits. And service delivery, obviously, by looking at all of these things, the aim is to improve our service delivery. Can we make improvements, process changes? Sorry? Somebody speak. Okay. For digital enablers, we've spent quite a lot of time with ambient voice recognition software, using that so we spend less time doing our clinical notes. This software can integrate with our EPR, so it can update System 1 for us. We have different communication tools to message the patient and have the patient fill in things like questionnaires, appointment reminders, allows image sharing. There's lots of different tech things that we can to try and review and free up time for our staff to have more time with patients. So we have apps as well that allow us to access the system when we're out and about. So from mobile phones, electronic prescription service as well, which I suspect most trusts have now probably done to reduce the problems with paper records as well. And we've got a shared care record system as well, which allows us to look at not just the mental health record, but the acute hospital record or the ambulance record, so we can see more information about the patient, so we can do better sort of delivery of care. Sorry, I'm very conscious I've overrun massively. Do you want me to stop, Ellie?
And I was just saying, if anyone had any questions, are you happy for me to pass them on through to you if they come through after you've gone?
And the slides will come out, so the ones that I've missed, you'll be able to have a quick flick through, I think.
Yeah, I'll send them through afterwards as well. Great, thanks so much, Claire, though. That was really good. I hope you enjoy the rest of your week. And I'll send Claire's slides out as well. Next, we're joined by Richard Sawyer, who is the Head of Innovation and AI Development at One NHS Finance. And I think, Rich, you're on the call.
Hi, Ellie.
Hello.
Hi, everyone. Yeah, all good. Shall I crack on?
Yep, over to you.
Great. Thanks very much for having me. My name's Richard Sawyer. I am, as Ellie said, the Head of Innovation and AI. So I'm just going to put up some slides, and I'm here to talk to you about Evo, which is free of charge end-to-end 20-week framework that comes in a 189-page project management book. It's delivered by multidisciplinary teams supported by finance, costing, and project and facilitation staff already at your trust. So essentially this is you and your teams working together to a set structure to be able to use patient level information to validate or invalidate your clinical assumptions based on your services. So it's built from the ground up by One NHS Finance, and I'll talk more about it as we go through now. Just to give you some context on what you are looking at in that main slide, these are all AIs that I've built for various purposes over the last year. 3 of those are from NHS England. The one at the bottom right has been built for the fraud teams and has ended up saving the NHS England counter fraud team about 50 hours every month, whole-time equivalent, which has significantly improved the efficiency of that team and the output as well. The one at the far right, the Evo one, this 189-page program has been ingested by that AI chat, and you can interrogate all of the details, all of the resources contained within the framework. There's over 100. There's all this value-based healthcare bits and pieces involved in there, and that AI is available to any trust that wants to start using this as a framework for evidencing clinical hunches using the most important data set we all have, which is clicks. Okay, so moving on to the deck itself. I wanted to first sort of start talking about value. So I'm sure you've heard quite a lot about productivity during this call, and obviously efficiency as well. And the view here, essentially at the Innovation Forum One NHS Finance's value is viewed in many different ways. And if we think about efficiency and productivity, really the productivity is the chief end output of working away at how efficient and making more efficient processes and structures. So we are more productive if we can work on the efficiency. There's no point doing more of things that do not work or are inefficient. We need to focus on the efficiency, and the overall payoff is improved productivity. However, these terms aren't always the most helpful when talking to clinical staff working in multidisciplinary team formats. You're all familiar or vaguely familiar with different versions of the value equation. It's defined in many different ways, and as a result, sort of widely regarded as a concept or theory of measurement rather than actual measurement itself. So for the purposes of Evo, we've tried to keep this extremely simple, but ultimately the value is defined as outcomes or quality at the top there in yellow, relative to the costs or resources. So that's to say, it's widely acknowledged that focusing solely on cutting costs without maintaining or enhancing the quality of care can lead to false savings and harm the delivery of effective care. Okay, so we cannot, as healthcare providers, continue to make decisions about quality and cost separately. And this is where the framework came about. It's that we had lots of SIPs, cost improvement programs, and QIPs, quality improvement programs, happening to the same service in parallel in different areas. And if we want to focus on sustainable quality improvement, which I'm sure we will do here now, we need to consolidate those two interests into one. And the value equation presents the perfect way to be able to balance the interests of quality under clinical outcomes, patient experience, patient safety, and also the resources that we used. Luckily enough, we have a data set to support the resources component of this in PLIX, which is extremely granular. There's a lot of opportunity. You will have heard about ABT technology being used, and we would really want to encourage that. So those of you that are familiar with the clinical coding sort of backlog, ultimately, the average sort of national, after a month of submitting activity information per trust, we have about 5% of all that activity is uncoded. So that's been growing from 1% to about 5%. And that correlates to quite a significant amount of uncoded activity, which makes it extremely difficult to catch up with. I would say that the use of AVT is going to transform the clinical coding process, and within a relatively short, I would say, period of time, it would be quite achievable to be able to resolve a huge amount of that backlog with the introduction of AI technologies, etc. Hoping to be able to work on a project of that later on in the year. I suppose what I'm saying with this is the PLIX data set is the most important and the most valuable data set that we have in our trusts, and the improvement in the quality of input is a priority. You've heard from a lot of costers today. I think the average in a trust, I think you've got 0.5 whole-time equivalent per 100 million resource given to costing. That's extremely small when we think about it. So a separate program of work to look at trying to improve the amount of resource we have whole times in costing. And actually, you could argue that that is the most significant purpose for future finance teams in the new world we're moving into. So it's a very exciting time, and this data set will only improve in quality, but also the number of people that are allocated to building a model that is useful for you to validate your clinical assumptions. So it's a very exciting time. And what we've done in EVO, in the framework, is put together a set of tools that allow you to quantitatively measure quality and the quality outcomes and clinical outcomes throughout the process, compare them against the resources required to deliver various changes at specialty level, and you can come out with what we have called the value impact comparison score, or VIC score. So if you go through the EVO process at the beginning and you make the changes to your service, 20 weeks later, you will have made that change, and we can use Plix to map the change through a process called PDSA Plus, which is literally the measurement of activity and resource information throughout that change. And we're able to articulate that while factoring in transparently the quality components and the resource components within that, which is an extremely powerful way to calculate the changes that we should be making, manage the risk that is needed to be able to make those changes, and move forward in our services across the board. I'm not going to go into too much detail on this, but that's the sort of high level. And the people involved in this is clinically led, but driven by finance and project individuals. So it's built to be very clinically light. So if you took part in EVO, which tackles in that 20 weeks, 3 clinical services over a period of about 3 months, and the clinicians would only be required per service to attend 1 2-hour session each month. The rest of the work is done by the champions, who are the director level sponsors at board level, and they sign a commitment to doing EVO for the trust to protect the time for the leads to be able to do this work. So we've got our finance lead there, we've got our 3 clinical leads, and we've got our delivery lead, which is essentially your project manager, and you've got your improvement lead there, which would be your facilitator. Obviously, we've got additional participants, so specialty service nurse, etc. This team is built by design to be extremely lean. No more than 7-8 people are involved to make the decisions that are necessary over this time. We've also got the timeline here. So the 2 blue ones there, the launch and the landing. There's a little bit of a space theme here, but it's a good way to disentangle the sort of finance and clinical quality and resources clash that tends to happen at the beginning. So we sort of bamboozle people with this space methodology, but by the end of the process, everyone is talking in terms of value-based healthcare and value impact comparison scores. So it's a useful device, and we should have a bit of fun with what we're doing in work. It helps to bring the teams together, and that's been proven through the pilots and the sites that have run. If we look at the launch and the landing, so these sort of bookend the process. The launch, we have all 3 services and all leads and champions attend. That's the kickoff. And you've got 3 sessions in between. So you've got formulate, evaluate, allocate, and decide and plan. The landing is where everyone meets at the end to do their sort of show and tell across the 3 specialties. And then the transformation is the change taking place. And then there's a final impact assessment where we calculate, each team calculates their VIC score. This is all a bit too much information for you, and your teams will be, if you take this on, will work away at all of this detail and become experts in the trust before we even start off. So in terms of formulate, evaluate, allocate, and decide and plan, broadly what happens within those 3 is we identify 3 clinical assumptions or hypotheses in the first session. We ask you to record in one of the tools what good looks like. In terms of the factors of patient experience, clinical outcomes, and safety. Record what good looks like, and then we're using those measures and the Plix data to validate and evaluate, allocate, validate the hypotheses. And then if they're validated by the data, then you go on to decide, plan, and prioritize those changes based on capacity to change, risk, safety, etc. And there's a few tools to help you do that. These are the 3 tools, and when we've got a chance in the next couple of months, I'm going to turn those from the sort of manual tools that exist as resources, downloadable resources from the book, into a piece of software. It won't take too long, and these will be extremely useful for collecting value measures for different specialties. We've got them for respiratory and various others as well already. The priorities tool to help you prioritize your changes so that your transformation team has an idea of need and prioritization for the changes that you want to make. And then you've got the impact tool to essentially calculate the impact of change that you've had. And this presents itself as a percentage. Okay, so 25% before we started Evo, 25% improvement can be seen across quality and resources. And this is an extremely useful metric of improvement that can be taken to boards and above. There's a few QR codes here. These are very poorly made by my own hand animations to explain some of the stuff that I've shown you. I'll share the slides so you can have a look at that. And in the bottom right, there's Nottingham, who I believe you heard from today in this session already, and Nottingham, sort of the trailblazers of some of these principles for the structure in the WAVE program. Those of you that have heard it, so Scott and Richard have. I've learned a lot from them, and we've worked together to develop the VIC score as well. So you can see their application of the VIC score in this session as well, and we've got a few more coming as well. These are some of the expected outcomes, and we've worked with a number of trusts already as well, and continue to. There's anyone here from London Northwest? You've just started your first Evo journey as well, so the team are getting up and set and getting ready to get on with that. So that's very exciting new trust that's joined. And if we look at the various specialties that we have put through across acute and mental health, mental health are often considered as sort of not as material information for when it comes to PLICs to be able to support decisions. However, we've actually found the opposite. Some of our most successful site is now an Evo Silver site, which means they've put 6 specialties through this process and have identified significant redesign and benefits. Number of the acutes, the larger acutes, change can be quite challenging because of the scale of that. We found significant benefit with a large maternity trust in the Midlands who are looking at and implementing almost 2-hour time save for the discharge process in the maternity ward for pregnant mothers. So that 2 hours is quite significant, and we're hoping to get the information on that very soon as well. A few examples from North Staffordshire Combined, who is the Silver mental health site. This was a significant change for the adult memory service, and North Staff's combined healthcare team led by Dr. Becky Chubb won the Royal College of Psychiatrists Team of the Year award. It was a fantastic piece of transformation. You can see the reduction in tests, the decrease in DNAs, and obviously the implied cost benefit of that transformation. In addition, one of their other transformations essentially involved a text reminder service, and with the support of the data team who worked really hard on getting that information together because they're quite understaffed, as I covered at the beginning. Worked very hard and identified an opportunity which ultimately allowed them to recover 925 outpatient appointments, which is a massive amount of clinical time recovered. So we're seeing pockets of success and transformation and change all the way through these sites. And one of the most significant things we're observing is the MDTs and multidisciplinary decision teams have been formed across sector in different specialties, and we've seen quite a lot of continued work in Evo and outside of Evo, and an appetite for making decisions and change. And we've found that that's actually sometimes the biggest barrier is making change and then actually going ahead and measuring it. So we never do that in the NHS, measure the impact of the change once we've made it. It's the most important item, and hopefully the VIC score will support through that. I don't know if we've got time for questions at all. I've tried to rattle through that to try to get us back on time, Ellie. But if anyone has any questions, they can contact me at the Innovation Forum, or would like to find out more. There's a QR code there as well. Thanks very much for listening. Cheers.
Thanks, Rich. I think, AK, are you back on the call?
I am.
Great. I'll pass over to you.
Thanks, Ellie. Any questions for Rich?
There never is, AK. I don't know what that's about. I must be doing something wrong. I need to. I need to send you the AI. Actually, I only published that last week, so you can. I'll set you up with that and give you a shout. Thank you for having me anyway.
Thank you.
Appreciate it.
Thanks,
Thanks,
Rich.
Rich. Bye.
Right, I'm back again. You've got me for 2 more talks. So this one on clinical coding, and the final one of the day a bit later on business cases. Again, I'm stepping in to cover a gap. I'm not a clinical coder, but I was the coding lead for our trust for a while. So I do have some knowledge of this particular area. So what I'm going to do is I'm going to give a little bit of background based on using our animation that we've got, talk to some of the basics of it, and then give you some examples of issues and problems that we've had, solutions that we found, some of the kind of pitfalls and quirks of clinical coding in the NHS, and how it's affected us as an acute trust. It is primarily coding is in this form is primarily designed. We're talking about the acute system. They did trying to improve coding and activity data collection in mental health and community. It is a lot harder. They've tried the clusters, mental health clusters, but they haven't really got the finesse and fidelity that they would like in terms of resource management and things like that. So, it's very hard to work out. Somebody with schizophrenia can be very high intensity or quite low intensity. So that within the mental health system, clustering, which is their version of coding, is not as straightforward. And also, we'll touch briefly on outpatients and the ED, but this is primarily focused on inpatients. So we'll go through the video, the animation, which covers a lot of this, and I'll try and pick out some key points in it.
Insurance feels better when you've just used Confused.com.
Poltroni Sofa is here with special introductory prices exclusively at SES from March 12th.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilising the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organisation's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are healthcare resource groups, or HRGs? A healthcare resource group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge. Coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations. Here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
Okay, so as I said, we're going to focus on inpatients. The number of clinical codes that are available in outpatients are much, they're basically a lot fewer. Okay, and the tariff is much more limited. So coding is based on these healthcare resource groups, which are because of what the tariff is based on for those that are those for the elective work, essentially for activity-based coding. So it covers elective outpatients, elective inpatients, emergency inpatients, certain direct access and outpatient diagnostic services, so MRI scans, CTs, and what's below there, and some nuclear medicine services, and unbundled, so some chemotherapy deliveries bundled into another bit of care, but this is for unbundled chemotherapy delivery, and some radiotherapy. It doesn't include outpatients because they have much more limited numbers. They're all coded to these ones, which are basically by the treatment function code, and you have essentially you either have a unidisciplinary or single professional or multidisciplinary clinic, and you have new patients and follow-up. That's basically what they are. Occasionally you can get outpatient procedures coded into within the outpatient coding, which then develops extra money, but primarily for outpatients that you either get, they're either new or follow-up, and they're either single disciplinary or multidisciplinary clinics. So HRGs take into account the admission method, length of stay, the age of the patient, and then as well as what we said before, which was diagnoses, any treatments or procedures that have been carried out, and then the patient characteristics. And you can see that on this that you have, for example, this one, it's intermediate procedures for congenital heart disease with a Charlson comorbidity score. And these are the comorbidities of 0 to 3, 4 to 8, and 9 plus. Okay. And the comorbidities are weighted differently for different conditions. So not all comorbidities have equal weighting for each condition, and there are whole books and that have the weightings for each comorbidities. For example, if you break your hip, then osteoarthritis is as a comorbidity is not going to score, because almost everybody who has a hip replacement or has osteoarthritis. If you've got some sort of cardiac thing, then that will be something that generates a CC score. Okay, and so different comorbidities have different weightings depending on their the seriousness. So liver failure will generate maybe 3 or 4 on its own, whereas something quite mild may only have score 1, depending on the original HRG. Okay, and you can see that the financially it goes up for day case and elective. They have these trim points, which means that the expected duration is either a day case or it's an inpatient stay. In this case, for the 0 to 3 and 4 to 8, it's 5 days. So after 5 days, if the patient has to stay in hospital for longer than that, you'll get a token per patient per day amount of money extra, but it probably won't cover the cost of that patient stay. Okay, for those extra days. So it's to encourage you to get patients out within the time frame that within the trim point time frame. And you see here, this has got the extra bit here. So this is for non-elective, for emergencies. You've got, it's obviously they cost more, and because they're emergencies or urgents, then the expected duration or duration of admission is longer, and then you get this per day long stay patient payment for if you days exceeding that trim point. Okay, and you can see £318. A cost of admission overnight in a standard ward is probably roughly about £500 per night. So you can see that you get some money, but it doesn't cover the cost of delivering that care. And that's the key thing, cost and price. How much does it cost you as the organisation to deliver that care versus how much income you're getting to deliver that care? And if you're not making money on those ones, particularly the high volume, low complexity stuff, you've got to change your pathway. And something in your pathway that doesn't work. So you get your primary kind of diagnosis, as we said, your procedures, comorbidities, any interventions, laterality, so left or right, and you can see you have the interventions. They come from the APCS code, and you get an HRG. The market forces factor is, as we said earlier, it's a multiple. You multiply tariff by the market forces factor, and each organisations have their own market forces factor, depending on the cost of delivering care in that area. So as I said, Northumberland, Cornwall will have higher market forces factors because they have a rurality component. London has a higher market forces factor because the cost of living is high there. So pay the London waiting, all those other things that mean that the cost of delivering that care is higher. Okay, so as I said here previously, each for the condition, the comorbidities have a score depending on what the underlying procedure is, so or the underlying condition is. So as I said, depending on the HRG, the different conditions have different scores. And here's just a demonstration of the importance of documenting comorbidities. So your baseline HRG, I don't know why we've got this one has congenital heart disease as the main HRG, but you can see that the primary diagnosis is probably the same throughout, but if you add in extra components then that are relevant, then it increases your base tariff, and then you add in the market forces factor. I think this is based out of Manchester, maybe. So they've got slightly higher market forces factor. So then you get increased income in total. And so for the same procedure with extra comorbidities, you can, it's just like it's almost double, over double the income for certain non-elective procedures. So you can see that comorbidities is really important. So, as I said earlier, we've done various things to try and improve our clinical coding. Some of which have been successful, some of this were initially successful and then have fallen by the wayside, and others are still ongoing. So the first thing that you've got to make sure you try and do is identify and capture activity. So there's a lot of activity that goes on in hospitals that's probably not recorded properly. And what I mean is that they may not be entered onto any hospital system. If they're not entered onto a hospital system, then there's no data record of them actually attending. Particularly things like ward attenders. So if you've got, we had a scenario where we had lots of dressing changes done on a particular ward, so it wasn't done in outpatients. They were patients that were inpatients for a while, got sent home, and came back to the ward for dressing changes and things like that. They were scheduled. They had a nurse allocated to them, but it was on a piece of paper, and they booked it in on a piece of paper every day. It wasn't on any of the computer systems, and so we didn't know that activity was happening. It was still costing us a nurse, so there was nurses that weren't able to look after the patients, but it wasn't being captured, the data. We had a weird quirk where some of the MRIs that we were doing under general anaesthetic weren't being recorded in the correct system. They weren't being recorded in any theatres, and they were just on the MRI, but then you didn't factor in that they were having general anaesthetics. So there's weird and wonderful things that you might find when you're looking and interrogating your data that mean that the data is not being captured. Patients are sometimes admitted incorrectly, so they're then, particularly with things like same-day emergency care, if they're admitted onto the system as an inpatient, then they get coded, but often the notes are not good enough to then actually generate anything useful. Z codes and therapies are interlinked. So Z codes are patient characteristics that often affect, they're often non-clinical, so they're not medical diagnoses or anything specific. They tend to be social characteristics that can affect patient care. So things like mobilizes with a stick, or lives alone, or needs hearing impairment, visual impairments. I mean, significant visual and hearing impairments. They're often recorded in therapy notes, so either in physio or occupational therapy notes. And we found, I think it was something silly like £10 million worth of opportunity, let's say. So once the coders got access to the correct system, which was where the occupational therapists and physios were documenting, they identified that actually that would increase our income across the year by 10 million. Now, whether the commissioners could pay that extra money is a different question, but especially if we do it retrospectively. But going forward, we could use that incorporate that into our discussions and contract negotiations, but also into our coding. Okay. It also affects things like your standard hospital mortality rates and things like that, because those things can alter the expected mortality. So it's important to factor that in. Our codes are non-specific symptom codes, essentially. So they're codes where patients have come in with a symptom and they've been sent home without a proper diagnosis being documented. chest pain. So somebody comes in with chest pain, it's non-cardiac chest pain, but rather than being diagnosed with anything specific like, musculoskeletal pain or something like that, they've just been diagnosed as non-cardiac chest pain and sent home. And or so they basically have a very low mortality rate. And so you can get to a situation where and they don't attract as much funding, those non-specific symptom diagnoses, as a proper diagnosis. So even musculoskeletal chest pain will drive more income than non-cardiac chest pain. So just the change in wording can make a difference. The other big component about R codes is that they can have a big impact on your mortality rates, because particularly if you've got multiple consultant episodes. So you saw in the animation that a hospital spell, so that the patient's journey is broken up into these fixed consultant episodes. We had, and we still have this issue where every time there's a change in shift, particularly on the medical wards and the admission wards, so our acute medical wards, every time there's a change in shift, that generates a new FCE, new fixed consultant episode. And the problem with that is that if somebody comes in at 6 o'clock in the morning with chest pain, by the time so that's the overnight consultant, that's the FCE, then they get a consultant from 9 sometimes till 1 o'clock, and then there's another consultant from 1 till 5. And if their diagnosis is done after 5 o'clock, even if they get diagnosed with cardiac chest pain or some sort of heart attack or angina or something, then what you find is that you find that for the purposes of the mortality scores, particularly SHIMI, standardized hospital mortality index, it's only those first 2 episodes, or data in those first 2 episodes, that counts towards that. And so we've had this issue where poor coding and a change in how the mortality index has been calculated has meant that we've just had a massive decrease, a stepwise decrease in our mortality score, through no change in clinical practice, but purely because of how it's calculated in our coding issues. Okay, so there are lots of these things that we've encountered. The reason why they've had to do that, creating a new finished consultant episode for every time the consultant changes, is to do with acting on test results, which we had a historic problem where we had test results that weren't being acted on or weren't being noticed. And so to ensure that the consultant who ordered the tests actually acts on the tests, they put the system in, and it's a quirk of the admission system. But how do we identify these problems? Okay, so the next thing is about using PLIX, where you can look at where where you're losing money, particularly, as I said, on those high volume, low complexity things. And in a lot of cases, you might find coding errors. Now, that may not be due to the coders, that may be documentation issues. So how it's been documented. Leeds have been very good at this. They've done lots of work, and Nottingham to some extent as well. So Leeds they identified various issues, but for example, in cardiology, they looked at their PLIX data and noticed that there were certain angiograms, so what seemed to be standard angios, so cardiac angiograms, that were taking twice as long. And when they investigated further, it's because they were being coded in a similar way, but they were actually different procedures. So it was a much more complex procedure using a specialized bit of kit, which meant it took double the time. And they were losing income, but also it impacted their mortality index and benchmarking. Okay, so there's a big potential way of identifying coding errors, from clicks. Okay, so and that's the first step. So when you do your clicks analysis, and then similar in the way that Evo works, the first thing is data assurance. So you look at your data assurance. You look at is it a coding issue or is it a pathway issue, and then you build on from that. And that way you can look at stepwise. Is it a coding issue within the coders and access to the right system? Is it a coding issue in terms of they're not the terminology being used is not as clear, or is it documentation issue? Are we not clearly documenting the differences between the different procedures? Okay, so that's the kind of purposes behind it. The key thing when documenting, and increasingly what's happening with the digital electronic records, is that we are still using IC10, even though a lot of the world is using IC11. NHS England and the kind of the digital component, we're not looking to move to IC11 for at least 3 or 4 years. But those ICD terminologies is generally not how clinicians talk, and not it uses slightly different terminology to how we describe things. And so what they are doing is a lot of the electronic systems use SNOMED, which is a different type of nomenclature, which is more aligned to how clinicians talk and document things. And so in the background is this process, and eventually it will become automated, but currently it's not. That as we shift to more digital sources, the SNOMED terminology will be matched to ICD-10 and coding, and the coder's role will be to be more quality assurance rather than actually going through the coding. But it does require on clinicians accurately putting those SNOMED terms in properly, try and avoid abbreviations. And it's this, so our hospital are in this dilemma, that we're in this in-between stage where coders only code from digital records, but we are still in hybrid. So we document certain things on our electronic patient record, but we still document mostly on paper. Our day-to-day notes are on paper. And whilst we've been trying to encourage clinicians to document primarily on the electronic paper record and maybe put more abbreviations and things in the paper records, because that's not being used in the same way for coding, there is this the world hasn't caught, the medical legal system hasn't quite caught up yet, and so or the belief is that it hasn't quite caught up yet, in that there is still a perception that it's the paper records that are the medical legal record, where I don't think that's strictly true anymore. But that's where we're having issues with our coding, particularly things like op notes. So we need to make sure that we've had to make sure that all our op notes, operation notes, are put onto some digital platforms one way or another. So ideally do it on our theatre recording system, but if they do paper ones, we're trying to get them scanned in onto the digital record. So it's trying to come up with workarounds initially. And then the final thing is making sure that people understand the differences and the importance of documenting properly, both for medical legal and for coding purposes. As I said, there's a separate set of data called the emergency care data set, which is used for emergency and urgent care, so ED attendances and some same-day emergency care. There are 107 fields. There are four main components: the reason for attendance, the chief complaint, acuity, and diagnosis. It's a much more limited. So the ECDS only allows certain terms, and so it's a much more. That's why it's done at the point of diagnosis. So the ED clinicians will enter it onto the system directly, and coders don't tend to get involved with the ECDS system. But it is used primarily as a database for clinical kind of governance purposes rather than income generation. So that again was taught on clinical coding. Any questions at all? So I would say it depends on your organization. So most coders do not or will not interpret COPD, TAVI, AAA, or any of those NSTEMIs. Some have got specific. So we've got a thing about interpreting BMIs. So our coders can interpret, but we don't tend to use obese, very obese, or morbidly obese in our day-to-day in documentation. We tend to put BMI, and so they have been allowed to this equals that as a we've allowed that. They are pretty strict, which is why SNOMED terminology doesn't allow those kind of things. It does vary between organizations, and if there's something that's very commonly used and there's no other interpretation for it, you might be okay. But officially, and if you speak to my coding colleagues, they do it quite strictly. Any other questions? So clinical coding is a minefield. It is something that you often find is you only find out later on about the problems, but it's worth looking into your own systems to see how things are worked, how things work. I'll hang around for another 5 minutes. It's another coffee break, screen coffee break for till 3 o'clock essentially, where we come back with the introduction to primary care finance. I'll be on here for another 3 or 4 minutes if you have any questions, but otherwise we'll see you back at 3 o'clock. Hello and welcome back. Hope you feel refreshed. We're in the last session now. Still to come, introduction to primary care finance, understanding budgets and spreadsheets, and then finally a talk on business cases. Okay, so moving straight on to introduction to primary care finance, we have Andrew Roberts, hopefully, who's Senior Finance Manager at Leicestershire and Rutland ICB.
Hello. Hi, AK.
Andrew.
How are you?
I'm all right, thank you. How are you?
I'm good, thanks. I'll just share my screen. I've got a presentation. Just bear with me.
Thank you.
Did you see that?
Yeah, we can see that. Over to you.
Great. Thank you. So I think I've got half an hour, haven't I? So quickly, a quick run through of how GPs are paid. So my name is Andrew Roberts. I'm Finance Training and Development Manager, as AK said. Up until about just over 12 months ago, I was the finance business partner for Leicestershire and Rutland Integrated Care Board, looking after primary care and prescribing budgets. So, and I've been in that field for a few years. So hence the reason why I'm talking to you today. Just a bit of an introduction first before we go on. So Leicestershire and Rutland ICB is a ICB in the Midlands of England, population just over 1.2 million patients. It's mixed rural, some very rural, with county towns and the city population. But we've got sort of pockets of significant deprivation across both city and county. We are in the process of reorg at the moment, and we are clustering with Northamptonshire Integrated Care Board, which is a little bit smaller than Leicestershire. So we're in the process of doing that at the moment. We have an annual budget allocation for Leicestershire and Rutland of just over £3 billion from the government. That includes everything, including running costs and the services that we pay for from providers. Our main provider is University Hospitals of Leicester, which is the acute site in the middle of the county, and also Leicestershire Partnership Trust, which is non-acute LD and mental health. The budget for general practice is 270 million for this year, and we have a prescribing budget of 226 million. And we're also responsible for paying community pharmacists, dental contractors, and optometrists since NHSE moved that delegated those services across to the ICB a couple of years ago. But this talk is mainly on GP funding. On screen now is a list of all the elements that I'll go through, some more briefly than others. So we've got core contract, the QOF, enhanced services, right down to local authority payments. So GPs are paid on a core contract basis. So there are a number of different types of contract that GPs hold. Most of them are a general medical services contract, which is a contract without end, so it's in perpetuity. The partnerships generally change over time, so people come off the partnership agreement. The GPs will come off the partnership agreement as they retire, but new ones come on, so the contract just carries on. We also have a personal medical services contract and an alternative provider of medical services contract. The latter is was used more recently to commission primary care services, things like out of hours or GP services, and they're time limited and have more of a quality element to them and a bit more specific. But we are trying to bring them all together so they're all similar. And the government is committed to reviewing the core contract as we speak. So we're just waiting for information on that. So the core contract and a lot of the APMS contracts are list-based. We've got the Carhill formula, which was implemented about 20 years ago. This produces like a weighted capitation figure for each practice. As I say, we've got a list of 1.2 million. I think the list, the weighted list is something like 1.1 million. So there's and the weighted list takes into account of things like care home patients, age, sex, demographics, and rurality of practices to try and compensate practices for dealing with those elements of the population. Their current payment is £123.34 per annum, and that's paid monthly. It's revised quarterly. The list sizes are taken from the practice's clinical systems on a quarterly basis, and the payments adjusted accordingly. They had an increase of 9.6% on last year on the 24-25 rate. They also can opt out of a number of services, so out of hours and minor surgery, and the amounts in brackets are the percentages that they give up of their core contract for not having responsibility for providing those two services. The ICB is then responsible for commissioning both out of hours and minor surgery. Most all practices in Leicestershire have opted out of hours, so we're fully responsible for providing or commissioning an out of hours service. And then there's practices have access to a redirector each year, and they're able to look on the link at below to identify and give them an idea of what their income will be from their core contract and other elements so they can do their normal planning routine. So that's GP core contract. There's the quality and outcomes framework, which is an incentive scheme that was introduced again about 20 odd years ago. Started off about 1,100 points, but it's slowly been whittled down. We're now on 564 points. We have clinical domains. So there are a number of domains that the quality and outcomes framework covers. So there's clinical domain, which is 537 points. And that includes things like atrial fibrillation, coronary heart disease, heart failure, hypertension, diabetes, and asthma, amongst other things. And then there's the public health domain, which is 127 points, which covers blood pressure monitoring, smoking cessation, and vaccines. Each practice, they get £225.49 per point for the average practice. But if there are larger practices get paid in proportion to that. So that's for the average practice. If the practice was twice the average, they'd get twice 225.49. So that's sort of how it works. Practices are continually monitored on their quality and outcomes framework performance. There's usually a big push this time of the year, Q4, to get their points increased. So you might see a lot of activity with asthma checks and diabetes checks and things like that, so that the practices can maximise the number of points that they achieve. And we then go through a process in Q1 of the following year to verify those figures, and the practices are paid their balance figure around June time. During the course of the year, they're paid an aspiration amount so that they've got cash to run on the quality and outcomes framework, and then there's a top up or an adjustment in Q1 based on their actual performance. Yeah, so that's the quality and outcomes framework. All practices have access to enhanced services. So there's the learning disability health check and minor surgery enhanced services. There's also a primary care network participation payment, which currently stands at £1.76.1 per weighted patient. And there's the new advice and guidance item of service payment as well, that's been introduced recently, and that's been introduced to get greater working between secondary and primary care and try and shift activity from secondary into the community. So that's being paid at a rate of £20 per item of service. So that's those are the enhanced services that we currently commission. We've got also, obviously, each practice runs from a particular premise. There are a number of reimbursements that practices claim for during the course of the year. So these are amounts that, or payments that they receive from the commissioner. So non-domestic rates bill each year comes from their local authority. They forward that to the commissioner and we will reimburse them. Again, water rates, they don't stand the cost of the water rates, the commissioner does. So they submit their invoices as the case for clinical waste. So any clinical waste contracts that they have will be reimbursed by the Commissioner as and when invoices are submitted. Each practice is either rented or owned by the partnership. If they are renting the practice, the actual rent will be reimbursed, and this is verified by the district valuer. So we will only pay for rent if it's considered to be value for money. Again, practices submit their rental invoices, and the ICB will reimburse them, as is the case for health centre rent. So health centres are generally properties that are owned by NHS Property Services or CHP Community Health Partnerships. So for the old Liftco buildings, I know in Leicester City we had 5 or 6 Liftco buildings built in the 2000s for primary care. They're all run by CHP, and we pay, and the practices or the tenants of those buildings, which includes practices, are charged to use their facilities, and we reimburse the practices through the premises cost directions. So they submit their invoices and we pay them. And notional rent is where properties are owned by the partnership. So the district valuer will check the practice, the premises, and calculate a notional rent value, i.e. what would the rent be to the practice if it was rental property, and then the practice are paid that rental, the notional rent value for the year, and that is reviewed on a 3-yearly basis. So it's updated every 3 years to take into account things like premises, quality and local rates. A few years ago, a number of there was primary care networks were implemented by the government. This was a way of trying to get practices to work closer together, be more resilient as a service. We've got quite a few primary GPs who were single-handed in our area, and obviously if one of those goes on sick or loses their contract, then that causes quite a lot of issues trying to get alternative provision, usually at relatively short notice. So primary care networks were implemented to try and make the system more resilient. They're usually on a geographical footprint, so practices in the same area would join together and work closer together on a number of items, a number of areas. We've got about 20 PCNs in LLR that work closely together, and they generally have like a single practice who receive the money and then they distribute the money across their membership. And these on screen now are a number of the funding streams that primary care networks receive. So member practices all receive a participation payment of £1.76.1 per weighted patient per year. That's for being part of a PCN, taking an active role in a PCN, and going forward. Primary care networks receive a core funding of nearly £3 per patient, and this includes clinical director monies and leadership and management, so the cost of running the PCN. Enhanced access scheme is worth £8.52 per adjusted patient. and the investment in an impact fund is 20p, and that's similar to the quality and outcomes framework, but it's on a PCN footprint. PCNs get a care home premium of around £130 per bed per year, so £10, just over £10 per bed per month for all the care home beds that they have in their patch. And that's to facilitate ward rounds, check their patients in their care homes, and make sure that those patients are being seen. And I suppose the outcome is to reduce admissions into secondary care when not needed, really. There's the capacity and access support payment and the capacity and access improvement payment, which show the rates on screen. And that's all about improving access to primary care services. So the practices work together in order to provide a service that's sort of over and above the core hours, which is 8 a.m. till 6:30 p.m. So there might be evening sessions or weekend sessions covering the whole patch. So you might not see your individual practice, but you might go to a practice that's part of the primary care network. These also introduced as part of the primary care networks was the additional roles reimbursement scheme. This has continued into 25-26 with more roles being introduced. So we've got things like, or roles like health and wellbeing coach, the care coordinator, physician associate, and first contact physios, and also newly qualified GPs are now in there, and digital and transformation leads. We all know that one of the key elements of the future NHS is to move from analog to digital, and they sort of take that role forward in the individual primary care networks. So those are the additional roles. Our budget in Leicestershire is about 31.3 million. So as you can imagine, that's quite a lot of staff that are now reimbursed or employed by primary care that are reimbursed by the ICB. They do have to be additional roles, so they can't have been in the original baseline of the practices to ensure that this money is being invested in the right areas. So those are sort of the primary care network payments. There are a number of other payments and support that we provide to practices. So, for example, locum costs. So practices, if they experience any maternity, paternity, or adoption leave for their partners during the course of the year, then there are rates for reimbursement. So for the first 2 weeks, they are allowed to claim 1,475.17, and that goes up to 223.03 for each week thereafter. Also for sickness, obviously, if a partner is off due to sickness, they need to cover their sessions. So the practice is able to claim the same amount, 223.03 per week for sickness. And likewise, if a partner is suspended for any reason, then there's a rate on screen that we are due to pay for them to support the practice on reclaim or providing a service. So there's a whole process in place for practices to claim their locum costs during the course of the year through a reimbursement process. Practices also get paid for prescribing fees and drug costs. for dispensing practices. So when they dispense, they get a rate. A dispensing practice basically is a practice with a small a pharmacy within the building. They are allowed to dispense drugs to certain patients on their list who reside further than a certain amount of meters from a community pharmacist. They then get paid, reimbursed for those drugs costs. And all practices get paid a fee for raising a prescription, writing an FP10, a prescription. We pay for those as well. They also get their Care Quality Commission annual fees reimbursed, and based on their annual invoices. And just a note there that the immunisation and vaccination programme will be delegated to ICBs from the 1st of April in 27. So we're taking on more services, but that's another sort of 12 months away. We also have community-based services. So these will vary by ICB. We've got, these are locally agreed payments. Payments are based on activity in most cases. And in LLR, we have a system called CQRS Local. Practices can put their details and their activity onto that on a quarterly basis, and then payments are made in the following month. And on screen, you can see some of the examples of community-based services that we commission from our practices, and include things like shared care monitoring for complex drugs, minor injuries, and dressings. We've also got local enhanced services for INR or anticoagulation monitoring service, H. pylori breath tests, and diabetes enhanced services, which we also pay on a quarterly basis. Some of the other funding streams, so general practice IT, so any kit that's in the practice that's linked to the network is paid for by the IT, Integrated Care Board. We also provide their email and their clinical systems, and we also pay for any SMS text messages that they send out to patients. The prescribing budget, we've got a prescribing budget of 226 million this year. This includes the cost of the drugs prescribed, and any administered or dispensed at the practices. So that's a cost that they don't cover. We've got the budget. There's a whole process of when the prescription is dispensed. The community pharmacist takes that up to, sends that up to Newcastle, and then ultimately our bottom line, our allocation is top sliced for the cost of those drugs. We do report that back to the practices so they can see where they are against their notional budget. NHSE also provides payments to them, and that, as I say, includes vaccinims this year and next year, but it also includes GP trainee support, so the registrars who are spending some time at practices to train. There are some payments that are associated with those. Local authorities also make payments to practices, and I've put on the screen a couple of examples: contraceptive services, smoking cessation, and drugs misuse. Part of the 10-year plan, just put this screen in just to identify what's expected going forward. So Department of Health and Social Care are going to undertake a review of the Carhill formula, just waiting for timescales. Funding's likely to be the same. Neighbourhood health services are going to increase, so shift from hospital to community. as I said earlier, moving from analog to digital with online consultation tools available during core hours. More and more practices are using online consultation, GP Connect access for the record. More and more patients can go through and see their record online. NHSE will be abolished, and we're obviously going through the management of change at the moment. Our ICB footprint will include Northamptonshire. Well, it is at the moment. We're clustering with a view to merging in probably from April 27, but we're just waiting to hear from that. So that's a quick fly through. I think I've got a minute left. Any questions? Stop sharing my screen. Any questions? Is that? No.
Can't see any questions at the moment.
Well,
give it another minute to. Well, thank you very much, Andrew.
Quick run through, but I think you've got the gist, hopefully.
Okay, so thank you very much, Andrew. I can't
you.
see any questions yet, but we can try and visit them later on, and I'll try and answer them towards the end. Moving on, we've got Christina Puccini, who's a finance business partner at Alderhay, who's going to talk about budgets and spreadsheets.
I bet you've been looking forward to this all day.
Some people have, I think, so yeah, understanding them. So,
I do not jest. I love a nice spreadsheet. Like, who doesn't? So, okay, hi everyone. I'm just going to share. Is it okay? Am I sharing my slides?
Yeah, go for it.
Just please bear in mind that I'm on a single screen, so I won't be able to see much, if anything, of the chat. If anybody does say anything, or if anybody wants to ask any question, feel free to interrupt me as I go. I don't mind. So let me just share what I've got here. Can we see that?
Yeah, all good.
Excellent. So in that case, let me move that, and we'll get going. So hi everyone. I say that and I can't get this thing to move on. There we go. We are here today to go through a budget statement, I should say understanding budgets and why we set them, and potentially what do we do as budget holders, what's our responsibilities. So what I'm hoping to cover for the next half hour is the age-old question: what does finance do for us in true Monty Python style? How the NHS funding flows, what different parts of finance do, because we do have specialties ourselves, budget and how to set them, and then finally what budget holders' responsibilities are all about. So hopefully we'll be able to kind of go through this in the next allotted half hour. I will introduce myself. My name's Christina Puccini. I am a finance business partner at Alderhay, and that is my lovely team. As you see, I am very, very proud to work at Alderhay. I have spent almost my entire NHS finance career here. I had a brief stint at another trust, but then I came back, and I feel very proud actually to represent us here in front of you. So there you go. So that was us being nominated for one of the Alderhay Oscars, which sadly we didn't win, but never mind. So without further ado, then, what does a finance department do? Well, if you at its heart, at its most basic, the finance department is here to make sure that we receive all the funding that we need, and with that we use it to to achieve the best possible outcomes for patients. So in a nutshell, that's what we're here to do. We're here to facilitate that. And the way that we I want to say we like to do it, I hope we all do it, is by aligning ourselves to our trust values, because this allows us to support all the services, all the actual patient-facing activity services with improving quality. And how do we do that? We do that mostly through support with obviously all things financial, but also governance and standing financial instructions. Now, I know that looks like a really busy table. It's just there to give you an idea of the sort of thing I'm talking about, and that is just an example of spending limits for different hierarchies within the trust. But in essence, I like to think of governance almost like our PPE. It's a suit of armor. It's the thing that allows us to work in peace and in good conscience, and to actually discharge all our obligations and make sure that we perform everything that we need to do in accordance with the law. So it's there to protect us, really. I appreciate sometimes it can seem a bit dry, a bit stifling, but that at heart, it's its purpose. And in a nutshell, that is what finance do. So with that kind of generic idea of finance in mind, what I thought I'd do first of all, I'd just quickly take us through the current way that NHS funding flows. Obviously, all of this you heard before about how NHS England is going to come to an end at some point within the next 10 years. So things will change. However, in general, the NHS is funded through taxation, so all of it, most rather, I should say, of our funding comes through government, and the government spends about 11% of GDP on health. So at the moment, NHS England allocates a lot of this, and the ICBs allocate the rest, or to the ICBs, but soon the ICBs will be kind of taking over. And in general, all NHS trusts and foundation trusts receive the bulk of their income through contract with the ICB and NHS England, and we'll come across this in a minute as well when we talk about different parts of finance. But in general, we, as you saw before, primary care are predominantly independent contractors, so they kind of again receive the funding through the ICB, but the largest share of healthcare spending is generally taken by acute care, so provided in hospitals, like Alder Hey, for example. So this is how roughly super high level the funding kind of flows through the NHS. So what then happens within finance to help you with managing these funds? Finance, like I said, has a number of specialties. So, for example, we could start with management accounts. That's where I work as a finance business partner. And what we do, effectively, we give business support to divisions. We give advice. We can give training. We set the trust budgets with you, and also we help you monitor monitor divisional performance against these budgets that you set, and we'll go that in a bit more detail in a minute when we talk about the budgets themselves. But within finance, there is also the more statutory branch of the department, and this is financial accounts. Financial accounts, as opposed to the kind of monthly monitoring and forecasting that management accounts do, look at annual statutory accounts. So, and they'll also provide the treasury service, all the cash handling and collection, all the cash management. They collect all the income, and they also generally encapsulate the capital arm of finance. So they'll be dealing with investments and long-term assets, as opposed to the more annual in-year kind of focus that is within management accounts. Within financial accounts, you tend to find accounts payable and accounts receivable. So these are the specialists that deal with either paying suppliers or receiving cash from clients or government, as it were. Now, accounts payable are obviously critical as account receivable to the NHS, in that they process all payments to suppliers, and this is where some of the SFIs and some of the regulations and governance within finance comes into its own, because they will ensure that all the necessary procedures are adhered to ensure safe payment to bills. For example, in my trust, we have now for a couple of years now implemented a no purchase order, no pay policy. So unless somebody has a valid purchase order, we won't just pay an invoice, and it really helps us make sure that budget holders really are aware and happy with what is getting paid. Accounts receivable, on the other side, make sure that all the cash comes in, so they collect, they deal with all the invoicing, there's all the sales invoicing, and they make sure that all the income that is due to us arrives. Now, many organisations usually have a commercial arm, and this commercial arm generally deals with operational or business development plans. They usually go into tendering, business case facilitation. They usually help with market intelligence and that kind of information. They generally are there to maximise all income possibilities and income generation for the trust. So this kind of takes different shapes depending on the organisation. You then have income and contracting, which sounds very much like accounts receivable, but they are more management and contracting arm of finance. So effectively, they report on the income, and they make sure that all income is correctly accounted for. But they are also instrumental in setting up and maintaining the contracts that we have with the ICB, NHS England to an extent, to ensure that we receive all of the necessary income for the activity that we have agreed to perform in year and in future years. They also make sure that all the activity collected by coders is captured correctly, which again is another way to ensure that we do receive all of the income that is due to us according to the activity that we performed. And on a slight kind of tangent, was very close to income and contracting, that is usually costing and improvement. Now, costing generally look at the streams and expenses within a hospital from a slightly different angle from, say, management and financial accounts. They kind of tend to go for service line reporting and patient level costing. So again, very closely connected to the coding and activity. And this kind of information is usually really important for budget holders, especially in clinical activity areas, in order to help them to make effective business decisions. So within finance, these are the kind of groups that you will generally come across, and each has their own specialty to kind of support you in different ways. So if we go back to my world of management accounts for a minute, then now we can see what budgets are and really why we need them. So first of all, what is a budget? Well, the budget is a financial plan that outlines the expected income and expenditure for a specific period, typically a year. So like I was saying, management accounts deal a bit with the here and now of this year. So they will monitor expenditure monthly, will forecast for the rest of the year, but generally it's typically within that particular year until obviously you get to the end and we come straight into the next year. However, what this means is that planning this way, it just helps the NHS and departments to deliver services within its financial means and meet its legal and financial duties. So we're back to the governance. We are supposed to deliver the agreed activity within a financial envelope, and this helps us helps us do that. And we control through monitoring the monthly budget and making sure that we forecast ahead for the rest of the year so that we can stay within the agreed limits. Now, in this, like I say, budgets within the NHS allow us to plan, but in this financial climate, the really, really important thing is the grip and control that as budget holders we can make sure we maintain over our areas, because this is what allows us to maintain independence. Because effectively, the more an organisation loses control of its finances, the more the ICB will take control of the organisation's ability to make its own decision. So the grip and control and knowing and working within your budgets and working with your finance teams to make sure that we're all pulling in the same direction is one of the ways in which we can ensure success. Budgets, of course, also make us accountable. So as a budget holder, we'll ensure that all the costs incurred are valid. So we're back to the purchase orders to an extent. So making sure that we are masters of our own domain, I guess. And finally, all of this together is what allows us to achieve the activity level. So going back to what we promised we were going to do at the beginning of the year, for which we're receiving all the income that we require, but controlling our behaviour as we go. So that's the why we need the budget. So, okay, then, how do we go about setting it? How do we go about setting a budget then? Well, first of all, we're going backwards, I guess, at this point. We set the expected activity. So we have a look at what we have agreed and contracted to do for the upcoming year. And there you go, as lovely Ben at All the Hay, one of the ward chefs, ready to feed the children on his ward. So Ben and pay, obviously not just Ben by himself, but pay is the main ingredient of NHS budgets. It actually accounts for up to 75% of the cost of any organisation. So we need to be really, really careful when we set a budget, that we understand what that means and that we understand how to deal with the cost of people. And that is why you really do need to work closely together with your finance department. Because, for example, we can all go on NHS employees and look at the Agenda for Change pay scales, but obviously we need to understand that there are other costs, there are other on-costs that go to make a pay budget, and so we run the risk of actually undercooking our plan if we don't fully understand the consequences. And there's a little bit of audience participation. I say that, but I can't see what you're going to do, so answer the question in your head. So in your opinion, which of the following best describes staff on costs? Is it A, travel expenses, B, taxes and contributions, C, uniform and equipment costs, or D, bonus payments made for exceptional performance? Well, for those of you who are thinking B, you are correct. And that's the reason why salaries on their own are not sufficient for you to kind of set an acceptable pay budget. So having dealt with the pay, what do we do? Well, I guess everything else. So non-pay is very simply everything else, the rest. So what we tend to do with that is try to organise the different types of non-pay so that we can broadly have an idea of the sort of things we need to take into account. And there's roughly 4 categories. We have operational costs. These are like utilities, rent, maintenance of equipment. We have capital costs, which again have a consequence in year, but typically stretch for a number of years depending on the life of the asset. We have supplies and materials. So these are office supplies, any manufacturing materials. And then finally, we have services. So these are anything consulting, any outsourcing, maybe legal fees, marketing. And when you do all this with your finance department, generally speaking, what you'll also find that the trust also sets aside an amount for inflation. So for any of these contracts that you've got going on year, there is usually an amount of non-pay inflation, which is then added to the budget. So I appreciate this slide looks a little bit busy, and I don't want to read through it, but effectively what you see here is a snapshot, but not an exhaustive list of what a budget holder's responsibilities. And I'm sure none of these things will surprise you. I mean, the obvious one is to engage with your finance department, because in that way you engage in setting budgets that are right for you. You can review them to make sure everything goes as you expect it. Manage the budget in line with SFI, so accept the purchase orders, follow the trust rules, check your staff. You'd be amazed. Sometimes payroll errors occur, so it's really good practice to make sure that you methodically check all your pay information every month. And then, raise queries with your management, account and planning team, because honestly, that's what we're here for. We're here to help you dig into anything that is unusual, different, incorrect, and we can help you fix it. And then you can use this information to make future decisions and plans. So other things you do need to do is completing staff change forms is really important, keeping the staff system, the payroll system up to date. Again, make sure no overpayments or leavers are correctly dealt with, etc. And then going back to the governance from before, in terms of non-pay, approving the order of goods and services, so you're fully aware of what is being spent out of your budget, and then approve invoices in a timely manner, because the NHS prides itself in being a responsible payer, especially with small suppliers. Make sure we don't keep them waiting beyond the agreed terms. But like I say, underneath all this, ask for help. That is truly what we are here to do, and we'd much rather help you before something goes wrong than having to help you fix it, because usually it doesn't take as long. So at this point, assuming I can get this thing to move again, there we go. We can play a little game, but I say that, play a little game, but I'm not sure how much time we've actually got to play for real. So again, you can have a little look in here, and there are answers in the next slide that you can consult later. But effectively, this is a reasonably normal example of a budget statement. So they do vary between organizations, but you will find in general they follow this pattern. They will have the spend split into pay and non-pay, sometimes income as well, depending on the nature of your business. It will give you details of the type of spend, so it'll break the pay into different bands. It'll break the non-pay into all the different types of spend that is associated normally with your department, and you'll have annual budget, the spending month, spend up to that point, year to date, and a kind of final variance at the bottom that tells you how well or how badly things are going. These can change, so the way that they're presented can change from one organization to another. So sometimes a minus is a good thing. Sometimes a minus is a bad thing. In this particular example, a minus is a good thing. So and then you can see, so you can find your there's a bit of Where's Wally. Just look at the question. So here we could look at what is the annual total pay budget, what is the year-to-date position, what is the account code for furniture and fittings, and a reasonably interesting one, this one, the pay line for the nurse at band 6 is underspent for this year, and can you explain why? So like I said, unfortunately I haven't got view of the chat, so I'm not actually suggesting you do this for real, but you can check your answers. You can check your answers later. But for the last one, if you correctly spotted that the funding for nurse at band 6 is 5.83 whole-time equivalent, but we've only worked, paid for 4.91, it follows that we're paying less than we've got in budget, so we're making a little bit of a saving. And when you get these slides, the answers will be in the next in the next slide. So for in terms of what I wanted to go through with you today, admittedly a little light-hearted moment, because I appreciate that spreadsheets are our bread and butter, they're our specialty, that's why we're here. But I'm here to try and convert those of you who are not interested or are a little bit afraid of spreadsheets and have a think about using them. What you'll find is Microsoft Excel is the main kind of spreadsheet you'll find. I think most organizations use Microsoft, and I appreciate it is a specialist tool, but please don't be scared. As with every piece of software, it's got an undo button. So if anything goes wrong, you can always unpick it. And I find that most I've done it with some of my service users. I've done little sessions to kind of teach them the basics. Some IT departments have in-house courses that you can attend, or even there are some of these support, you know, like SDN, forgive me, it's been late in the afternoon. I forget the name of the network, but there are places where you can go for basic Excel courses. And if you have a little play around with it, what you'll find is that it will really improve your communication with your finance department, because we'll be able to kind of give you slightly more complicated information, and we'll be able to kind of work with you, really digging into what the problems are. So don't let Excel scare you. It's actually a really, really good tool. But if it really isn't for you, just ask us. I'm sure all of us will be more than happy to construct things that, you know, costings or other bits of information that you'll find useful. So in terms of a summary, what we've gone through today is finance, what it does, how NHS funding flows at the moment, why and how we set budgets, what are the main budget holder responsibility, and I hope what is now revealed as the hidden beauty of spreadsheets. And I will leave you, before we have time for questions, should you have any, with this lovely quote, which takes me back to the grip and control, which is: a budget is telling your money where to go instead of wondering where it went. So bear that in mind as you navigate your way through your new budget. And yes, if you at this point have any questions, I will be happy to take them now or take them away later. Or if I don't know, I will definitely have to come back to you later. Well, thank you.
Thanks, Christina. Any questions on budgets and spreadsheets?
Stunned them all into silence again.
Yeah.
I will take it as a compliment that it was so clear that nobody has any questions.
No questions, but positive comments. There you go. That
is lovely. That is lovely. Thank you. I wasn't being facetious. It's actually quite a pleasure to come and talk here, and I hope it's useful.
I'm sure it's very useful. Okay. Well, thanks, Christina.
Thank you.
Not seeing any more questions, so we're going to move on, because I'm next. So I'm doing business cases. It's the final session of the day, and it's the one I always overrun on. So starting a couple of minutes earlier helps me. So thank you very much.
Excellent. Thank you very much.
So if you're not sick of hearing my voice, my fourth talk of the day, this is one I normally do. So this is one of my talks. So this is something that's I've been talking about for several years now. So we're going to talk about business cases and how they work, how you can write them, and some tips and tricks to getting them through the process. The business case process is varies between organizations, but they all should be based on the same principles. And that's the principles that are defined by the Treasury for all public sector business cases. So we're going to use the better business cases, or the 5-case model, as our structure. There are whole massive courses and assessments and things that you can do on business cases, but they are designed for people who look at multi-million-pound business cases all day, every day. They are not designed for most of us and most of our business cases, which are much smaller in both in value, but also in size. But I will touch on some of the processes involved. So let's start. So what is a business case? So a business case in general is a request for resource. So what you're trying to do is you're requesting more resource from your organization or from your commissions. Okay. But what it also is, and a key component of business cases, is that it is a record of your decision-making process. So why you've chosen the solution that you've chosen, or the option that you've chosen. So when you look back on it and reassess it, you can it's documentation of the thought processes. And one of the first things you have to do when you're thinking about putting through a business case is understand the process within your own organization. Okay, so what is the process? Who are the people that you need to get involved? Who are the people that will need to review it and you need to get support from? Often it's your clinical director or operations, head of operations, depending on your structure. So you'll need to get some management involvement. You need to get often need to get some financial involvement, and you need to get some your senior clinical leadership involved. Okay. Some people have, and it depends on the size of the business case, whether you and then whether where the money's going to come from. Okay, so is it coming from within your department? Often, if it's coming from within your department, a business case is not necessarily needed. If it's coming from within your organization, then you might need a business case. If it's coming from external, so whether it's from educational funds or the commissioners or from NHS England funding, then you'll need at least some sort of detailed application process, if not a business case. But the principles are the same in terms of the content. As I said, do you need a business case? Is it something that is just replacing like for like? Is it like that, or is it? So there's two sides to it. Is it? Do you need something bigger than a business case? Do you need a whole program with project management support and multiple business cases, or do you need something smaller than that? So what you've got to work out is the business case the appropriate thing that for you to spend time and effort and on. So if it's something more simple, you get an options appraisal. If it's something bigger and needs multiple business cases, then you might need a program. Okay, so they're the things that either side of a standard business case. So the next step is what we think should be in a business case. Now we're going to try and structure it in a proper way, and we're going to talk about what the components are. But generally, it's all the who, what, where, when, how, why. Okay. We're going to use the recommended 5-case model. Okay. It comprises a strategic case. Now this is where the clinicians have the biggest input. clinicians and the operations teams have the biggest input in the strategic case, and the economic case. The commercial case and the financial case are often specialists. You need either procurement and HR and finance to be involved in that, and then the final bit is the management case, which might need operations input as well. Okay, so it's a team task writing a business case. Very few business cases have no input from other people. Most of them should have at least advice or guidance from other specialities or other fields. I'm going to take each one as it goes along. We are going to focus on the strategic and economic case. The commercial case I've talked about in the procurement side of things, but we'll touch on it a little bit. We'll touch a little bit on the financial case as well. So the drivers for a business case. Now, the number one reason for business cases not being prioritized or failing or being poorly written is that they are often written with a solution in mind. They are written almost with one bit that's been well thought through, but the other elements of it haven't been. The problem with that is that the people reading a business case are not experts in the field in the same way you are. So you are, if you're writing a business case, will probably know in detail the issues surrounding that problem and why you've chosen that solution. But you need to kind of convey that across. So the best driver for a business case is to solve a problem. If you demonstrate there's a problem and these are the potential solutions and why you've chosen this solution is the best way of selling a business case. In some scenarios, you can do it purely on improving quality. So if you've got a advancement, a new thing that's come out and you want to, and it shows that it improves quality significantly, and or it reduces costs, then that can be used as a driver for business cases. But most commonly, the ones that tend to get the prioritize the most is solving a problem. Now, most business cases are good ideas. Okay, so most people, have sensible ideas for their business cases. They may not be the best solution, but they are all often sensible ideas. But with the finite amount of resource that you have, people have to prioritize the business cases, all the business cases that are put forward. Okay, and so the idea of this talk is to make sure that your business case gets prioritized. So that's what we're going to try and do, is help you write a good business case. There are plenty of business cases that get approved that are poorly written. And they are often ones where the idea or the proposal has already been discussed, it's already been approved, and the documentation is purely a tick box. Okay, so that people don't actually, or the people who approve the business case don't actually read the business case in any detail. It's just a documentation of the process. Okay, so there are some of those that get through, but we're going to try and get you to do good practice by trying to get you to deliver a business case properly. It comes down to demonstrating value. Okay, so again, you've got to show that quality improvement in at least one domain, but hopefully multiple domains. Okay, in the quality is worth the cost, and that's the revenue and capital cost. So this goes all back to that value equation that we started the day off so many hours ago now. If you have a big business case, if it's a significant value business case, in order to stop people spending too much time on them, they have some gateways, essentially. So you put your strategic outline case first, and then you might be asked to do an outline business case, which then puts a bit more detail in, and then your full business case, which is basically dotting the I's and crossing the T's in terms of the process. Most, not all, but most business cases that we write in the NHS within our organisations are either go straight to the full business case or just have an outline business case. They don't have the multiple steps. Okay, I'm putting this in purely so that you understand that if you have a big one, then you can have a step-by-step. You may be asked to do a step-by-step process and version of it, and that's just to make sure that it is the direction of travel that your organisation wants to go in. Okay, particularly if it's a high-value business case. Okay, so most of the ones that we do are a single step. And these are the kind of concepts that we would do in each of those steps. This is more for your slide deck for when you look at for referring to later, and rather than getting into detail about it. Though, if you have any questions, we can talk about it. The strengths, the SWOT analysis is your strengths, weaknesses, opportunities, and threats analysis. Okay. But we're going to start with a strategic case, and this is how your business case should open with. So the first bit of your business case should be the context of your business case. And all our organisations have priorities for the year, annual priorities. They have a direction of travel they want to go through. They have organisational aims and ambitions. Okay, you need to make sure that your business case aligns them. You've got to show why your business case kind of fulfills those aims and ambitions that the organization has. Okay, so what is the context within in terms of the organizational strategy? How does your business case fit to that? And that has to be quite early on, okay, because it needs to illustrate that. Because if it doesn't, then it gets deprioritized almost immediately. The next big thing that often requires a bit more work is the case for change. So why do we need to change? And sometimes the data is available, but sometimes you might actually have to do some data collection to be able to show that, depending on how it's what it is. And so different case for change kind of evidence base or weightings have different kind of value differently. So benchmarking is really important. So whether you use a model health system or model hospital or just other forms of benchmarking, getting it right first time, showing your performance compared with other organizations that are similar to you. Okay, they tend to be reasonable, strong evidence. CQC evidence is very strong, so that will, if you can show it's a CQC issue or something that's on the national agenda, then that will be highly weighted. Things that are we often use but are not always that strongly weighted are NICE recommendations and Royal College recommendations, and that's because there's sheer amount of them. They are something to aim for, and it's something you probably need to do over a period of time, but doesn't necessarily give you that much weighting unless it's a standard, unless it's a minimum standard that some of them put through. They kind of say this is an absolute minimum standard you have to achieve, then that will give you good weighting. But if it's just a recommendation and often, particularly if it's one of those consensus without a very strong evidence base, then it's something you should be aiming for, but may not drive your business case to the same extent as the other things. Okay. Mortality reviews and root cause analysis is also quite good evidence. So to give you some context and some examples, so this is from this is an old thing from my hospital system or my health system, the model hospital system. So this is one thing we use for our anaesthetic purposes. So desflurane is a an anaesthetic gas used to keep people asleep, it's very bad for the environment. But we were an outlier. We were using more of it than most of our peers, and certainly more than the national average. And so we use this as to obtain sustainability funding money. So it's specifically for environmental projects. And we said, look, we are a high user. If we get some bits of a kit, we can use an alternative method of delivering anesthesia that has the same benefits as desflurane, but without the environmental impact. And we were successful, and I took over as the kind of sustainability lead in I think it was September, October of that year, and within 6 months we managed to completely, well, maybe 9 months, we managed to get rid of desflurane completely from our organisation. So you can use these as drivers for change. Another one, this is again slightly out of date, but probably hasn't changed much. So this shows the length of stay for appendicectomies in our organisation, and we had quite a problem in that most of our patients stayed for longer than 2 days. And then if you use PLIX data, you can identify that the main reason for that is that they didn't get operated on until after 2 days. So it's not to do with our complication rate or anything like that. It was about access to our emergency theatre capacity, essentially. And so we use this to try and increase and improve our emergency theatre needs. So you can use benchmarking and available data to some extent. Sometimes you might have to do your own data collection to prove a point. So the other parts of the strategic case are the existing arrangement. So what is your current setup? So what is your current demand? What is the current situation regarding your service? How is your service going to change in the future? So what is your business needs currently? And you need to incorporate future plans and future increases. There's nothing worse than getting a business case approved now and then having to go back in 18 months going for the same thing again because you hadn't anticipated that increase need that you might get. There's always been things that are unpredictable, but if you know that your service or your demand for your service has been increasing by 2 or 3% every year, then you need to make sure that's factored in to your to a business case. Okay. So spending objectives and potential scope are similar in nature. So what are you going to spend the money on? What is it? Is it staffing? Is it building? Is it equipment? Or is it a combination of these things? And what is what is the aim of this? Is it a staffing issue or is it a building work issue? Okay, and that relates to the scope. Is it, for example, in the our emergency theatre scenario, we weren't looking to build extra theatres. That was beyond the scope of what I could achieve. It was more about staffing theatres, extra staffing in theatres in the evenings, and increasing our an extra team of staff for weekend work to try and catch up on some of our emergency theatre work. So that's what you can use. So that's what the scope and spending objectives mean. Okay. And the scope and spending objectives may be related to constraints. So the biggest constraint most people have is estates. So what available space you have. For us, it's theatres, it might be office work, it might be office space, it might be clinical space. What limits what you're going to be able to do? Okay, what's going to stop the scope of your limit the scope of your business case? So that's what constraints are. Dependencies are when something else is dependent on you achieving this business case. So if you've got, for example, if you've got you're building a daycare centre, okay, for orthopedics, for example, you might have another business case for the radiology support for that, but if you don't have radiology support for it, you won't be able to deliver all the things that you want to do in that orthopedic theatre. So that's where things are dependent on each other. We had a system where we were trying to move some of our ITU beds from one site to another, but we had another business case to increase our outreach critical care outreach service or to 24 hours, and it was one was dependent on the other. So being able to move our level 3 beds was dependent on having another type of support system in on that site. So that's what constraints and dependencies mean. And benefits and risks are, they're quite straightforward. Benefits are the positive things that are going to happen. Risks are potential things that might happen, negative issues. There's another word that's used in a lot of this documentation, that's disbenefits, and that's a bad word, but it essentially is negative impact that you need to make sure you mitigate against. And for context, what that could mean is, for example, we had a radiologist pitch a different way of doing breast screening programs, which involved putting a cannula and injecting dye into patients. It had brilliant results, but it took longer. And so the disbenefit would be, actually, unless you mitigated against it, you'd see fewer patients per session. Okay, so that would be, it's not a risk because it's not something that might happen. It definitely will happen. If you do this new way of doing things, you will only be able to see 8 instead of 10 patients, for example. So you either have to, which is a massive negative, and so what you either have to increase the number of sessions you're delivering, or increase the amount of staffing so that you can deliver the same number of patients. Okay, so it's a negative that's definitely going to happen, a disbenefit. Okay. So all of that needs to be in the strategic case, and this is why this is probably the most important bit. This is the bit that sells it. Okay, and make sure people think it's really important. If you're unsure on how to do demand and capacity modeling, the easiest thing to do is look at historic changes, look at how things have changed historically in terms of your numbers and demand, and then look at how that affects your capacity. And so forecast, if you've got specific things that increase it, factor that in, and so forecast for several years in the future. Okay, at least 2 or 3 years in the future. So if you have that increase of 2% or whatever it is that you need to do, you can then factor that in terms of how many additional lists that would mean, or what your capacity would need to increase by, and depending on the payment system available at the time. So this is from an actual business case from several years ago, not mine, what I found on the internet, but at that time you got extra money for doing these extra imaging. So you can demand a capacity model and then factor in the additional income potentially, and then how that would offset the cost of delivering that. So you can look at demand capacity modeling, factor in to a degree some of the financial benefits of it. But at this point, we're not really talking about financial benefits, because it is the payment systems change so often that you don't want to rely on that. So the focus is the demand and capacity component of it. The economic case is all about what available options you have and why you've chosen the options why you've chosen the option you did. Okay, so your long list, and this is again where I go back to the fact that you know your area, your service, probably in a lot of detail. The people reading it may not, probably don't. Okay, so things you dismiss out of hand that you think it's not going to work, it's never going to work, it's a non-starter, other people will ask that. So if you put it into your long list and think of all the various weird and wonderful options that somebody might think of that you instantly dismiss and put it in your long list, you can show that you thought about it, and it means that it just looks better. Okay. Your assessment criteria that you're judging the long list against needs to have 2 parts to it. You have your kind of essential bits, which are your critical success factors, what are the key things you need, and then you can put some desirables in as well. Okay, things that would be nice to have. If we're going to do this, let's do it properly. It'd be nice to have this. Okay, what are your fundamentals? What are your benefits? And then what you do is then you get it down to 3 or 4. Okay, ideally, the 3 or 4 is probably the ideal number. It must include a minimum option. So either a do nothing or minimum option. Okay, and for each of those options, you do a qualitative benefit. So what quality improvement is each one going to get? So, you know, if you're going to say it's going to increase outcomes, increase satisfaction, increase safety, to what degree is each one going to achieve that by? And then what each one will ballpark cost. Okay, so you have an idea of the cost implications for each option. Okay, so that shows that you have a kind of well-rounded thought process behind your business case, and you thought all the different options, and you've come up with a sensible idea. Okay. Now, people often struggle to get down to a shortlist. They often struggle to come up with a way of alternatives to their chosen option. So this is a recommended way of doing it, or potential way of doing it, and you divide it into the scope, the service, so solution, delivery, and implementation. Because we're all from different specialities and different organisations, I'm going to use HS2, the high-speed rail link, as a example of doing this. Okay, so the problem you're kind of dealing with is, in this scenario, is insufficient capacity on our rail networks between London and the rest of the country. So that's the problem that you want to solve. So the scope is, what are we going to do to solve? And this could be, you know, it could be a clinic, it could be increasing theatre space, there could be all kinds of, you know, scenarios. What the scope is, what is it that you're going to do? In the railway scenario, the minimum thing would be increasing the capacity between London and Birmingham. The maximum would be increasing the capacity between London, Birmingham, the Northwest, and Yorkshire. Okay, an intermediate would be doing London, Birmingham, and one of those legs. Okay, so that's what the intermediate would be. The how would be the how again is how often you're going to do it, and so in the railway scenario is you can refurbish the existing tracks. The maximum would be build new tracks. The intermediate would be a mixture of refurbishing and building new tracks. Okay, so it could be new clinics, it could be a mixture of extra clinics and extra something else. So it depends on how you're going to solve that. So these are independent things. So it's not you're not saying that what and how are related necessarily. The who in the railway scenario is local, national, international contractors. In clinical, it could be a nurse specialist, or the maximum would be a multidisciplinary team. An intermediate would be a consultant and a nurse specialist and a registrar. You know, there are various combinations you could use, but who is going to deliver that service? The implementation, when, is going to be all at once? Is it going to be stepwise? Is it going to be a combination of two? We'll start two from different ends, and then we'll meet in the middle, and then start the third one if we need to. Okay, and then funding is it going to come from public, private, or a combination of the two? Is it going to come from within the service? Is it going to come from a newly commissioned service? Is it from other pots of money? Okay. And over what kind of time period is that funding going to be available? What you do is basically have those. You put red, you mark as red the ones that don't meet your critical success factors or your key components, essential criteria. You put as orange any that are potential but you're not choosing, and green is your chosen solutions. And you put your rationale behind that for your choices in the text below. So that's one way of doing an options appraisal. Okay. And it shows that you've thought about it and thought about the different options and why, and explained why you've chosen what you've chosen. So a simple overview of the three cases is it needed? Why do we need to change? The risks and benefits, and well, what is the improvement in quality? The economic cases, is it value for money? So your qualitative versus cost appraisals, what options have been considered, and which option has been chosen and why. We talked about your procurement process. It is think about how you want to run it. Think about the whole life cost of whatever you're purchasing. If it's a staffing thing, it depends if you're on the agenda for change contract, which most people who are not doctors or dentists are on. Then the contracts are based on 37.5-hour working week. So you've got to make sure that if you've got to get the appropriate working time equivalents for the number of hours that you want to deliver the service for. So if you want extra nurse on a ward, that's one extra nurse across all 7 days a week, 24/7 is like 4 or 5 working time equivalents. So you need to get HR personnel can give you those working time equivalent calculations for you. Okay. For consultants, it's a 42-week year. So if you want delivery every week, it's slightly over 1 working time equivalent of consultant once you factored in things like annual leave and study leave and other components. So you need to work out whether you're doing this as a 42-week delivery, a 50-week delivery, or 52-week delivery. They tend to be the most common delivery methods. And when we talk about contract issues, it is purely about things like if you have existing contracts in place, then you may not be able to buy your new bit of kit. You might have to wait and feed into the next purchase process for particularly if it's for something that's ubiquitous. You want a specific thing, but it's used all around your organization. Then you might have to, if your supplier already supplies that bit of kit, then you might be okay. If you wanted somebody else's bit of kit, but your supplier supplies it, you've got to then work out what your contracts are. The other thing you want to be wary of is a compatibility issue. So if your whole service, particularly in terms of IT, is based on one company's IT product and you want to buy a different company's IT product, then you might find that there's some issues in terms of intracompatibility, in terms of drivers and all that kind of stuff. So we've had those experiences, so just be aware. It's not to say you can't do it, it's just you have to factor that in that time. Timescales are always quite important. So you're looking at a minimum of 3 months notice periods for most jobs within the NHS. For consultant jobs, people who are in training, the resident doctors that are finishing can be interviewed for a job up to 6 months before they start. So and there are certain people that interview now and then go away for a fellowship, so you might find you may not be able to get somebody post for over a year. So you've got to factor that in your timelines when you're putting your business case together. If you haven't got approval for your job plan even before you got the business case through, then it might take several months to get the various Royal College and university or whatever other approvals that might be needed before you even once you've got your business case approved, there might be a big delay before you can even put it out to advert. So you've got to be wary of all those things. If you are saying you're going to save money over it from your business case, what kind of time period are you aiming to save this money over? What is your break-even point for this? Because again, if you put that in, it gives you more weighting and evidence for your what you're selling. Okay. How's it going to be delivered is very much about the implementation process. Impact on service delivery is very much about not only the impact during the implementation period, so how you're going to roll it out, what's going to be your contingency if things don't go as planned, what's your backup system. We've got some new software. The next stage of IPR deployment means that we're going to change our theatre module. We're going to have to go down to paper for that. What's the impact on make sure we've got all the forms that we need, enough stock of it all. What's our contingency for if there's a delay in the updates? How are we going to make sure it's all accurately coded? We've got to think of all those different aspects of it, and then how we're going to get all that stuff back onto the electronic system once it's up and running again. So think about those kind of things. You might also have impact on service delivery as a beneficial thing. So if you are developing a new clinic, it might take away certain patients and create space in an existing clinic. If that's going to continue in its same form and you're creating a new one that's completely separate, you might be able to show that actually there's a beneficial component that will mean that we will be able to see more patients overall. So what's the impact of service delivery overall? So are the commissioners interested in the service? Is it an NHS England based service, or is it specialised commissioning, or is it localised commissioning? Does the increase in income, if there is income, cover the costs, and where are your funding streams? How much is already funded versus how much is needed? So those are the things you've got to try and put into your financial case. But get finance people to be involved in that, because they will help you. There are some specific terms that they use that are useful, but are not really something for us to discuss here. Get anybody who's affected by it to be part of the solution, get their feedback, incorporate their suggestions, so that when you do put it through, there's very little resistance. Okay, so get them, make them part of the process, so they don't act as blockers later on and delay your meetings. Can come on can be quite time sensitive, depending on your time of year and what you're trying to do. So don't anticipate potential delays, okay, and anticipate potential conflict, and make sure that they get involved in it early. Time is important if it's a small business case, particularly if it's capital funding. So if it's a one-off purchase, there's often, not always, often small amounts of money left at the financial end towards the end of the financial year. So January, February time. Often, sometimes they've had small underspends in capital projects, which means that they need to spend it because it's non-recurrent funding, and so you can buy bits of equipment and things like that. If you're trying to do a big service change, it's often best to try and do it from the start of the financial year, but be aware that discussions can start in the previous November with commissioners, so factor that in. Think about other forms of funding, so educational funds can be quite useful, or digital transformation funds, if relevant, can be useful. And if you have got a bigger business case that's relevant and you're buying bits of equipment, then you might be able to combine your business case with a larger business case that's already got some approval, or is going through the approval process at the same time. In your packs, you'll see examples of poor business case, for example. So this doesn't actually tell you anything. This is not a useful graph. If you're going to put diagrams or graphs in, make sure that they are relevant and actually save explanation rather than make more explanation. So that is my whistle-stop tour of business cases. I've run a few minutes over. Thank you for staying with me. Those that you stayed with me, you can watch it back on if you'd like. I'll hang around for another 5 minutes for any questions. I'd like to thank all our speakers. I'm sure most of them have gone by now, but I hope you found it useful. I apologise you were stuck with me for so much of it, and that it was a benefit. You'll get feedback forms, certificates, and the slides at some point, and links to the video as well. The approving authorities for business, it depends on who your business case is going to. So if it's an internal business case, you often have a finance and remuneration committee within organisations that approve particularly certain levels of business cases. If it's above a certain price, essentially a certain cost, so above there's different, certainly above £1 million, then it has to go to NHS England to be approved. Or the Department of Health and Social Care. It's slightly different if you're a foundation trust to if you're a non-foundation trust. So it is worth exploring the process within your own organisation. Obviously, education funds are slightly different. They're often approved by the Director for Medical Education. within your organisation, or external, heads of school, heads of the local training board. If you're looking for specialised commissioning, then it's your regional NHS England team that approves it. So it varies a lot depending on who you're talking to. Okay, I'm going to call it a day there. Thanks, Ellie.
Thanks very much. Okay, cheers. Thanks, everyone.
Thanks.
Bye.
Bye.